exaggerated introduction. So I do not have too much of a specialization, but this is more like from the crowd. This is a big lobby of pediatricians practicing neonatology. So I hope you can relate to what I'm going to be talking about. And let's try and solve this case together. Moving ahead. So this was really a neonatologist's nightmare. We had a 2-day-old male neonate who was born at term by LSCS. The baby cried immediately at birth and had a weight of 2.6 kilos. I have specifically written there was no MSL. There was mild tachypnea and distress at birth. So in accordance, the baby was shifted to a private hospital for observation mainly. And there the baby was taken on oxygen support. However, on day 2 of life, the baby developed tachypnea and distress, which increased further. And then the baby was shifted to us as a tertiary care center for further management. So just on this, most of the times, what risk factors do we think about is either prematurity, meconium aspiration, congenital diaphragmatic hernia, pneumonia and sepsis, pneumothorax, congenital heart disease, or just transient tachypnea of the newborn. Now, from my history, we have almost ruled out prematurity and meconium aspiration, but the others, we still have to work upon them. So, moving ahead with examination findings, the baby was dusky with feeble peripheral pulses. The heart rate was 170 per minute, which is high. Respiratory rate of almost 80 to 90. Saturation of 70% on oxygen, because we received the baby during transport, the baby was on oxygen support. A blood pressure of 52/18 and a mean of 29. So mind you, this is a term baby on day 2 of life. So definitely there is hemodynamic compromise over here. The BP is low for this gestation. There was grunt, very obvious, and distress. Heart sounds were heard, and there was no obvious murmur. And the cry tone activity were poor, but the baby was not limp, let me tell you. On these, before we could start investigating, we had to make sure that we are securing the ABCs. So we have taken the baby on invasive ventilation. Meanwhile, we have already collected the bloods. So moving ahead, we did a chest X-ray, ABG, routine bloods, and a 2D echo. So because we are a tertiary center, we try to do at least these investigations simultaneously. So here are the results. As we can see, the routine bloods do not reveal anything very significant. Hemoglobin is 18.4, WBC of 10,400, platelet of 3,11,000, and a CRP of 3.7. So we have almost ruled out congenital pneumonia or sepsis per se at the moment. However, when you look at the ABG, it's very clearly seen that the pH is 7.124, a PCO2 of 49, PO2 of 42.2, this is striking, and a bicarb of 13. So with a bicarb of 13 or say even 15, which is the actual, if we, rough calculation, if we add 15 to it, it is 30. 30 plus minus 2, that is what 28 to 32 was our expected PCO2. But here the PCO2 is 49. So what are we dealing with is metabolic with respiratory acidosis. So the baby is mostly in shock. But again, PO2 is very low, and this is in spite of the baby being on invasive ventilation. Here's the X-ray. Anybody wants to take a guess? Obvious. Pneumothorax. On the right side, right? So here we were almost sure what we are dealing with, a pneumothorax, mostly spontaneous because there was no MSL. So, but we still went ahead and do the 2D echo. Now, in the echo, I'll play it again. Can I get a pointer? Sorry. Right side and left side. Right atrium, right ventricle, left atrium, ventricle. Anything striking seen by anyone in this? The interatrial septum, defective. So we have any AST. This is the black and white mode. Then we went ahead, did the color mode. So you see a jet across the tricuspid valve. Okay, so this is pulmonary hypertension. The pressure is almost 78. Okay, so what was the systemic blood pressure we saw? It was 52/18, and this is almost 78, close to 80. So the pulmonary pressures were suprasystemic here. Okay, so it was severe pH. So the echo report said that it's a congenital heart disease and situs levosoletus, large non-restrictive ASD that we had seen of almost 8 mm, severe TR, severe pH. The RA and RV we had seen were dilated. This is because of pressure overload. The interventricular septum was intact, and the great arteries were normally related. Pulmonary artery and branches were dilated, and there was a tiny PDA, which may be normal in a just born baby. So I'll just, in short, summarize the case for you. 2-day-old newborn with respiratory distress, cyanosis, with query spontaneous pneumothorax, in shock with mixed respiratory and metabolic acidosis, pulmonary hypertension, and no obvious cyanotic congenital heart disease. So we had already started managing. Invasive ventilation was done, ICD was inserted. After the echo, we started on inotropes with pulmonary vasodilators. We started with noradrenaline and milrinone. IV fluids and antibiotics with other supportive care was started. Okay. Convinced? So after this, we were hoping we will have a good night's sleep. Anyhow, 4 hours later, just after maybe some improvement, the baby again continued to have persistent cyanosis in the form of low SpO2, and there was persistent distress. Now, in babies, it's a little difficult to say whether it is just peripheral or central cyanosis. What we did is we went ahead and did an ABG again here, and we see it's almost as bad, except mild improvement in the PO2 and the bicarb levels. PCO2 is rising further. So this is on the ventilator with the ICD, with the inotropes and pulmonary vasodilators, that the baby was still worsening. What next? Any thoughts from anybody? What investigation could we have done further? Or how else we could have managed? Okay, so let us revisit our causes for respiratory diseases, distress with cyanosis, with or without shock. So respiratory causes could be pneumonia, pneumothorax, meconium aspiration, congenital lung anomalies. With our X-ray, and so far the investigations that we have done, except for pneumothorax, I think we have almost ruled out everything else in the respiratory causes. In the cardiac causes, it could be a TGA, it could be truncus, but then truncus babies usually do not present with shock. It could be a tricuspid atresia, tetralogy of Fallot or physiology. Then total anomalous pulmonary venous connection, but the obstructive type. The non-obstructive types again will not present with cyanosis. LV dysfunction or a univentricular heart physiology. So again, most of these we have almost ruled out on our earlier echo screening. So what are the other causes that we could still think about? Sepsis. Sepsis can always be there with normal counts in a 2-day-old baby. Persistent pulmonary hypertension, which we have already picked it up, we have already started treating it, but then maybe we are still missing something there. Hemoglobinopathies with anemia, so no, there was no antenatal history, and even postnatal the hemoglobin was 18. Or disordered control of breathing because of any central cause. But let me tell you, the baby had cried at birth. Till day 2 of life, the baby was even active, so we are not thinking in terms of any major neurological cause. So our nagging feeling and instinct maybe, so we really wanted to revisit the 2D echo. So we went ahead, did it, and what you see here now, you want me to replay it? Or does anybody want to take a guess what was this? Absolutely. Agitated saline contrast test. So here you see that there is a filling in the right atrium, and just immediately after that there is a filling in the left. So anything with a right to left shunt. Why did we insist on repeating the echo? Because as we all know, ASD is primarily a left to right shunt. Okay, it was not a PFO because PFO can be either left to right or right to left, bidirectional. But here we were not sure. The cyanosis was out of proportion of the pulmonary hypertension, and we were already treating it. So we wanted to be very sure we are not dealing with any other anomaly like pulmonary AV malformations or pulmonary AV fistula or any other right to left shunt. And the only way to prove it without too much of an intervention is an agitated saline contrast study. So you can see it beautifully coming into the right atrium, left, almost immediately in the left atrium and the right ventricle. So what is agitated saline test? You have to take 2 syringes of 5 ml each for a newborn and infant. You have to fill the 5 ml syringe with 4 ml saline and the other one with 0.5 ml of air. And you connect it to a 3-way cork and you have to churn it. So you keep churning it, जैसे छाछ बनाते हैं buttermilk, you keep churning it. So when you churn it, micro bubbles are created. When micro bubbles are created, so that kind of creates a contrast when it is inserted into the peripheral circulation. So when it's entering the peripheral circulation, it will enter from the IVC into the right side of the heart. And it will get destroyed in the pulmonary circulation. So it enters the right side, it enters the pulmonary circulation, and then it will disappear. Only if there is a right to left shunt at any level, then you will see that it is entering into the left side of the heart also. Okay, so I have already spoken to you about this, but let's just see this slide. This is how it is connected, like this. Okay. And the agitation, like I told you, is done. And immediately after you agitate, you're supposed to insert it. Like you cannot let it rest, otherwise the microbubbles will disappear. So once you're sure you have enough microbubbles, you do it 5 to 10 times, and you get enough microbubbles, then you insert it. So what do you see? They diffuse into the lung when traversing the pulmonary circulation, so they're ideally supposed to disappear there. And only in the presence of a right to left intracardiac or extracardiac, that is pulmonary shunt, we will see it on the left side of the heart. So this is how it will normally be in a negative test. This is right side of the heart, this is left side. And this is how you see it even on the left side of the heart in case of a shunt. So once it has entered the right side, right atrium, and within 3 beats, you see it on the left side, then mostly your shunt is at the intra-arterial level. Intra-atrial level. Then between 3 to 5 beats, if you see bubbles on the left side, the shunt is mostly at the intraventricular level. And if you see it beyond 5 to 10 beats, then your shunt is at the pulmonary level in the form of pulmonary AV fistula or pulmonary AV malformation. So it's an inexpensive, easy test to do. And to be 100% sure that you're dealing with a right to left shunt, and once we were sure that we are really not dealing with any cyanotic congenital heart disease, what we had to do was we had to escalate our management for pulmonary hypertension. We had to go ahead, we had to add sildenafil and upscale our inotropes also. So this was something that we did, and I wanted to introduce the concept. It's inexpensive. I think most of the institutes can try implementing it, because literature says there have been 0.3% chances of transient ischemic attacks. So in institutes we can manage that, but besides that, there have been no other complications reported. Moving ahead, the next case is a short one, but again something we learned from. It was a 3-month, 10-day-old male baby brought by parents with complaint of poor feeding, cough, and worsening respiratory distress. There was history of a sibling death with us only at 3 months with similar complaints. At that time, that baby was thoroughly investigated for all anomalies, including inborn error of metabolism. The only positive finding that we had was pulmonary hypertension with high lactate levels on ABG. Unfortunately, we lost that baby. But with this one, we really wanted to be sure we are not missing anything. So again, here you see that the pulmonary pressures are high. There was pH to the range of between 50 to 55. And this was the X-ray. Nothing else very significant over here. But because there was a sibling death, it forced us to do literature research. And then we found that of late, there have been cases reported, similar cases reported, series being done. So baby had been treated for upper respiratory tract infection 7 days back, exclusively breastfed, and mother is predominantly on rice-based diet. So sir knows, I suppose, and sir must have dealt with, in your belt, sir, especially. Absolutely. So this was mother, the baby was exclusively breastfed. Mother was on polished and washed white rice-based diet. And our baby had cyanosis. There was respiratory distress, refusal to feed, and hypotension, lactic acidosis. So what I'm talking about is thiamine-responsive pulmonary hypertension of infancy. What is the mechanism in short? So this is a busy slide, but let's just focus on what is important to us. Thymine deficiency will lead to formation of reactive oxygen species. That will lead to conversion of nitric oxide to peroxynitrate, leading to pulmonary vasoconstriction. There are other mechanisms also leading to it, like in this case we had a URTI, which probably was LRTI. We do not know, baby had not come to us at that time. And maybe the baby had hypoxia at that point of time also. So re-emphasizing that whenever you see a baby in distress, even if it's an infant 3-4 months old, please make sure you're checking the saturation. Genetic predisposition could be there. So this leads to pulmonary venous and arterial hypertension, right ventricular dilation, deviated interventricular septum, systemic vasodilation leading to systemic hypotension, reduced afterload, and high output left-sided failure. So this cycle will continue here. At the same time, thymine will lead to mitochondrial failure in the Krebs cycle, leading to oxygen-free radicals, causing myocardial dysfunction. So all this leads to pulmonary vasoconstriction, leading to pulmonary hypertension. Now, this could just be also be a continuum of wet beriberi, right? In wet beriberi, we have a lot of cardiac symptoms, but it was not so known in infants, but now this is coming up. So these are the papers that I came across, all by Indian authors only. And the treatment is simple thiamine injection. At the same time, there was also a report of this in the American journal. This is an American study though, but this is in adult patients. So apparently, it cannot, beriberi might not only be other cardiac problems, even pulmonary hypertension is a very much known entity, and we should think on those lines. So we managed the pulmonary hypertension usually and added injection thiamine, 100 milligram diluted in saline, given IV over 30 minutes for 5 days, and once the baby is stable enough, we include it in their enteral feeds. Thank you.
Excellent presentation. And importance of this presentation is thiamine responsive pulmonary hypertension is a treatable cause.
Absolutely.
Easily treatable.
And otherwise fatal. We lost
otherwise fatal. And they typically presents at 1 month to 3 months or 4 months of age. So any child in this age group coming to you with respiratory distress, and there is no typical history of fever, cold, cough. They just present with distress, and you have to look for a cardiac cause in that. So it is a treatable cause, a nice presentation. And what happened to your first child?
So he came out well.
Yeah, it was a PPHN only.
Yes, we escalated the management, added sildenafil.
Dr. Prama, very nice 2 cases you said. And yeah, like sir said, thiamine responsive pH is now very much recognized everywhere. One of the largest series was from Bangalore. Dr. Jay Ranganathan had presented around 70 cases or so. Yeah, like sir said, in that belt it is more common, but then yes, we are seeing cases here also. Yes. Yeah. So yeah, in all, yeah, good thing, good presentations.
Thank you. Thank you.
On endocrinology, growing beyond unconventional path of growth hormone. I invite Dr. Aniket Kumboskar sir to throw light on this topic, and to chair this session, I invite Dr. Vasagdekar sir, a well-known pediatrician, well-known and senior-most pediatrician from Kolhapur, and Dr. Shrikant Sutar sir, an eminent pediatrician from Gadinglas.
So today we will just discuss very basic points about not common, a rare problem in your practice, but once in a while you will come across, and since it is a very subtle presentation, I think we have to keep your eyes, ears open to identify these patients. So this is a disclaimer from Pfizer. So idiopathic isolated growth hormone deficiency, it is the most common pituitary hormone deficiency in children. So as we know, there are various pituitary hormones which are secreted. But the most common disorder related to pituitary disorder is growth hormone deficiency. And specifically, if it is congenital, then there are very high chances that it may be associated with other hormone deficiencies also. And the diagnosis is combination of various factors, like the most important is anthropometry, clinical, genetic, radiological, metabolic, and hormonal abnormalities. So the most common feature is short stature, and as we already discussed, it is either congenital or acquired or idiopathic. So the pediatric GHD is complex and multifaceted. So how do you take a history in these patients? Most important thing, you should ask about gestational history. What was the gestational age at which baby was delivered, birth weight, birth length. So birth weight is very common. Okay? All of us, we are very used to take birth weight. We document it in every case paper. The one thing which is lacking in many of us, I'm not saying all, but we forget to take birth length, but it is very important. So all of us should try to take birth length and document it on paper, specifically if you are dealing with SGA babies, small for gestational age babies, because the growth velocity assessment can be done only if you have birth length. Then family history is also very important. You should always ask history related to signs and symptoms of hypothyroidism in any short child, because that is more common than GHD, and if you get that history, you should evaluate for thyroid disorder. Then one more common thing which we are dealing with currently is precocious puberty, which can lead to short stature, short adult stature. So remember, precocious puberty is a very, it fools us very badly, because early the girl will be very tall in a class, but finally she will be shortest in her class. So why it happens? Because the changes of puberty early, they have growth spurt early and they become tall than their peers. But along with that, the bone age gets advanced. So they will, that is like a story of, tortoise and hare, we know. So finally, who wins? The tortoise wins. So hare losses, because early puberty leads to early bone maturation and early epiphyseal fusion, and the girl will end up short. So when parents come to you and they are very happy that their girl is tallest in class, and there are, then the doctor should not be happy. He should be assessing the puberty if the girl is or the boy is above mid-parental height. So always one more important practice I think we should do is plotting a growth chart and assessment of mid-parental height. So suppose a mid-parental height is tall and the girl is tall, then you are not worried, right? But if the girl is tall and she's 2 standard deviation above mid-parental height, always try to assess the cause of early, tall stature, because it can lead to finally short stature. So physical examination, all of us are doing it. With special attention, you should do to dysmorphism and disproportion. So always, if you get a short stature child, first thing you should do is do upper segment, lower segment assessment and plot the upper segment, lower segment ratio. In your classic textbook in PG, we have heard that formula of, 1.7:1 at birth, then 1.3:1 at 3 years. But for your information, that is based on Western data. Now we have our own upper segment, lower segment ratios and parameters available. So always try to plot according to Indian data rather than that shortcut formula. Then you should always try to focus on any midline defect. So if there is cleft palate, then coloboma iris, so there are certain common midline defects. If they are there and the girl and boy is short, then always think of growth hormone deficiency or pituitary related problem. Now the next thing which comes is very challenging is growth hormone levels. So to diagnose growth hormone deficiency, we have to do growth hormone provocative testing. Random growth hormone has 0 value. So if you do random growth hormone and try to assess that value, then there is no use. So you always have to do growth hormone provocative testing. Then one more important parameter which we do is IGF-1 level. So IGF-1 level has advantage that you can do it random, and it is a surrogate marker of growth hormone sufficiency. So if your IGF-1 is coming low or very low, then you again get a clue that patient may be having GH deficiency. And the final thing is MRI. So MRI is always we have to do specifically in an adolescent boy or girl with suspected GHD, because you don't want to miss pathological problems like craniopharyngioma or germinoma or any CNS tumor which can present as only as growth hormone deficiency or short stature. And if you identify it as early without any symptoms, then the surgical outcome is very good. If you get a child with GHD and craniopharyngioma who has developed visual symptoms, raised ICP, then it is already late. So even if after surgery, the patient will have many morbidities. So any short stature with that particular age group with GHD, always we have to do MRI before we start any treatment. Then, so what is most important crux of this presentation is accurate and repeated measurements of weight and height. So height is a dynamic process. You cannot assess and label a diagnosis in one visit. So always try to do serial measurements of height and weight to give you a better idea about what you are dealing with. So what is the definition of this? So if patient is having height SDS below -2, below -2 is nothing but below 3rd percentile. Okay, you can take it. So below the last line on a growth chart is below 2 standard deviation. Then one more important thing is MPH. So if patient's height is normal, but he is below the mid-parental height. Suppose a boy or girl is having on his height on 25th percentile. That means what? By definition of population, he is not short stature, because what we called is below 3rd percentile is short stature. But suppose that boy's mid-parental height is on 97th percentile. So is he short stature? Is he short stature or not? Yes. So even though he is normal for population, he is way below for the family. So he is short stature and you should evaluate. And the third important thing is deviation of height percentiles. So suppose a patient is on 50th percentile and down the line 1 year he is gone to 3rd percentile or 10th percentile or below, just crossing the lines. Then even though he is in a normal range, since he is crossing the lines, that means what? That is indirect evidence that growth velocity is subnormal. So you should evaluate that patient. So these are the three, very simple clinical parameters you can assess. Now what happens in congenital growth hormone deficiency, that the presentation may not be very typical as simple short stature. So these babies or newborns may have hypoglycemia, prolonged jaundice, associated midline defects. So these are the clues of underlying hormonal abnormalities. So why I want to focus is, all of you are very good practicing neonatologists. So when anytime you get a hypoglycemia baby, just don't give dextrose and sit on it. If baby is not responding, if the GDR requirement is going about 10 or 12, always try to evaluate the cause of hypoglycemia. One of the cause may be multiple pituitary hormone deficiency. Then, so random GH is useless. You can see in this graph that the pulsatile secretion of GH and the most highest peak occurs in the night. Okay, so you cannot go and test GH at 3 AM in the morning in a patient. So there is no use of doing GH randomly. These are the tests which are done, and these are the provocative agents which are used. So Pediatric Endocrine Society is a US organization which tells us that provocative testing is important, but it is not required if patient has short stature and other pituitary defect which is evident. So if you get a baby who is having ectopic posterior pituitary, interrupted small pituitary stalk, and there is short stature, there is no need of doing growth hormone testing, because you know that the cause is there. Okay, it is evident. Then in newborns specifically, there is no need, because if you are suspecting if growth hormone is below 7 and there is associated hypoglycemia, it itself is suggestive that there is growth hormone deficiency. So these are the different agents which are used. I will not go into details. These are just different protocols which are used, but try to understand there is limitation of this provocative testing. So if patient is not mounting adequate response on growth hormone stimulation, that is not 100% diagnosis of GHD. You have to take into consideration all other parameters before you label GHD. So IGF-1 and IGBP3, these are the screening tests when you are not able to do GH provocative. At your practice, you can do IGF-1, IGBP3. It is random, there is no stimulation required, no fasting required, nothing. So there are data available with respect to age, the standard deviations, and if it is below particular for that age, then you can further evaluate for GH stimulation test. So what are the MRI findings commonly seen? So you can see this image. This is a normal patient's image. You can see this anterior pituitary, posterior pituitary stalk here. And this is a defect in which you can see the hypoplastic anterior pituitary, posterior pituitary is ectopic, and stalk is very thin. So stalk thickness, so whenever you order MRI in a patient suspected of pituitary problem, the sequencing or the imaging has to be done in a different way, so you have to talk with your radiologist. You just cannot say MRI brain. The anatomy of pituitary will not be visible. So you have to discuss with radiologist and do that sequence of images so that you understand the morphology of pituitary gland. And bone age, we all know, is very important in assessment, both in diagnosis and treatment of GHD. Now in various countries and various continents, the cutoffs are very different. So nobody is agreeing on a single cutoff here. As we know, hypoglycemia, there is no single figure which we agree. Similarly for GH provocative also, these are the different cutoffs given by different countries. And one more important thing which I think we should understand is priming is very important in certain age group. So what is priming? Priming is we have to give some certain agent before we do GH stimulation test. And many times I have seen growth hormone stimulation done and patient's growth hormone was low, was labeled as GHD, was treated, but patient was not responding. Why? Because the growth hormone stimulation test was done without priming. So if you do growth hormone stimulation test without priming, you get falsely low reports and you get falsely diagnosed as GHD despite normal GH levels. So if patient is GH sufficient, growth hormone is not going to work because your diagnosis may be inaccurate. Now we will go to the treatment part. So this is the journey of growth hormone over the last 30 years. 1981 first time, then 85 approved. 1993 first time approved for chronic renal insufficiency. 1907 Turner syndrome. 2000 Prader-Willi syndrome. 2001 for SGAs. 2003 for ISS. And the latest development, which I think we will discuss in few further slides, is long-acting growth hormone, which is there since last 2 years. So how do you treat GHD? The main goal is for optimization of height. The dose is very different. It is individual. We cannot give a fixed dose to every patient. The indication wise also, the dose is different. The dosages are lower in GH deficiency. The dosages are higher in other indications like Turner syndrome, Prader-Willi syndrome, and ISS. The most important thing is when you do growth hormone therapy, we have to monitor certain aspects. The most important monitoring again is height, weight, anthropometry, plus biochemistry, IGF-1, blood sugar, and thyroid function and cortisol assessment. Because initially patient may have isolated GHD, but patient may be evolving into other pituitary hormone deficiencies on treatment. So if you treat with GH and patient develops other pituitary hormone deficiencies, then your response may be less if you don't test it. Unless and until you test it, you will not understand the other hormone deficiencies. So it is very important in monitoring on treatment. So what are the challenges? The challenges are not only in India, but throughout the world, because the diagnosis of GHD is often delayed. So the two age groups, it is commonly done. But if you see why it is important to diagnose early is, earlier the age of initiation and longer the duration, it is the final outcome is better. So if you see here, even in developed countries, these proportion of patients were diagnosed very late. So even in UK, the 44.1% patient of GHD were diagnosed late. Okay, in India, maybe it may be 95% of patients are diagnosed late. What happens if you delay the treatment initiation? The outcome is very different. If you see this graph, the patients who are treated early, their changes in the height was much more good than the late treatment group. Now, one more challenging aspect for all this is low adherence. So you know, many endocrine disorders like type 1, these patients also has to take injections because we cannot give growth hormone orally. But the main challenge is the adherence is very poor. They have to take daily injections, so that also causes difference in the outcome. Those patients who have missed more than 1 or 3 doses in a week, their height velocity is much more poor than those patients who are adherent. So both clinicians and parents struggle with this adherence problem. It is very easy to say that you give daily injections, but practically we can understand the parents have to go through daily injections, and that is very psychologically, burdensome for those patients, even those of affording class. So the quality again is important. So those patients, quality of life studies are numerous, which show that those who end up short have many problems in their future life. So we'll just go to the final aspect of this presentation, which I want to highlight because this is a newer thing and you should know about long-acting GH. So, all similar disorders like this, which we are treating, hemophilia, type 2 diabetes, the traditional therapy was multiple pricks. So here hemophilia 3 times or twice or 3 times weekly was given, but now once weekly is available. That led to great adherence, robust hemostasis, low bleeding, no major safety concern. Similarly, in type 2 diabetes, many GLP analogs are available now, and initially they were daily, but now once weekly is available. So what is benefit of long-acting growth hormone? The frequency of injections is decreased, the adherence is improved, maximal efficacy is achieved, and flexibility is there. So this molecule was developed. This is a growth hormone molecule. The 3 chains of CTP are attached. One was attached at 5' and 2 at the 3' end, and that led to increase in the half-life. So the long-acting growth hormone has a half-life of 28.2 hours, in contrast to 2 to 3 hours of a short-acting growth hormone. And mechanism of action is same in both. Now we'll go through this efficacy and safety data, because that is very important. When we are going to give a new treatment, we should know that what is the efficacy and non-inferiority and safety of this molecule. Okay, so these are the studies which are done, and these are ongoing in this therapy. So if you see, phase 3 studies were done at 83 clinical sites in 21 countries, including India, and 10 centers in India were there, and 26 patients were from India. So what was done is, this was a 1-year study, eligibility, those patients who were fitting inclusion criteria were done randomization with long-acting versus daily for 52 weeks, and the primary endpoint assessment was at the end of 1 year, and the long-term study is continued for further assessment. So what are the inclusion criteria in this study was, the growth hormone treatment naive patients which are pre-pubertal, age more than 3 years, peak plasma growth hormone level less than 10, bone age and chronological age less than 10, the karyotype should be normal in these girls, and the IGF-1 was low. So this is the essential diagnostic criteria for GHD, and these patients were included, and the endpoint was 1 year height velocity. So if you see, the baseline parameters in both groups were similar, the age, peak GH level, height, bone age, and IGF-1. So if you see, the height velocity in long-acting group was 10, centimeter per year, and the short acting was 9.7. So similar. There was no difference in the height velocity. And some patients actually after 1 year they preferred and switched to long acting when they were offered a therapy. So after switching also in second year of therapy, the efficacy was good. And the main difference was treatment experience. So if you see the patient who are in long acting group, they were having good feeling about it, and they had the only thing which was problem in long acting was injection site pain, which was higher in long acting as compared to short acting. Otherwise, the ease of injection, convenience, satisfaction, all things were better with the long acting. Then bone age maturation was also similar, and the safety profile was also similar. There was no serious life-threatening side effect in long-acting growth hormone. And considering that injection site pain and other adverse effects, those with the adverse effect group also, there was no difference in the height outcome. So the summary, GHD is the most common pituitary hormone deficiency in children, and the major clinical features are short stature and poor growth velocity. Accurate and timely diagnosis and management are very critical, because delay in the diagnosis means the outcome is poor. So even if you treat a 12-year-old or 13-year-old boy or girl with growth hormone with severe GHD, the outcome may not be good because we are late. So you have to diagnose it early and treat early. Adherence to daily GH is challenging. So long acting may, in future help us. We are still very early to comment everything green for the long acting because it is a new molecule, but we are hopeful that it will improve the adherence of a therapy. And it is a new molecule with 3 CTP attached to GH, and phase 2 and 3 studies have demonstrated similar velocity achieved once weekly. The most common reported side effect were injection site reaction, and weekly administration was generally well tolerated in pediatric patients with GHD. Thank you. I just want to share one video which was not related to this topic, but I think was interesting because recently I met a lady at Las Vegas.
Nice to meet you too.
Which
I want to ask one question. Will robots replace doctors in future for medical management and health?
Will robots replace doctors in the future for medical management? This is a common concern amongst humans. Now that the topic is buzzing with potential, while robots and AI can assist greatly in the medical field by performing repetitive or precision-required tasks, replacing doctors entirely is not likely. Human physicians provide empathy, make complex ethical decisions, and understand the nuance of patient care in ways that robots can't fully replicate.
Thank you very much.
You are welcome, my friend.
So any one of you, if you go to Las Vegas, don't forget to meet this lady. Okay, she's Aura. Thank you. Any questions?
Hello. Thank you, Aniket, for covering this difficult topic and rare topic for us. Now the questions are, when should we start growth hormone in SGA babies?
HGA, yes. So HGS babies who fail to catch up by 3 or 4 years of age, we should evaluate and try to start at that age, 3 or 4 years, based on how much height standard deviation the catch-up is lacking.
Okay. Which girls with short stature we should do karyotyping?
Okay. So girls with short stature, by exclusion of common problem like hypothyroidism, and even if you don't get any dysmorphism or stigmata of Turner syndrome, I think we should do karyotype, because short stature girl without any dysmorphism can also have, Turner syndrome, and we should not miss it.
What is idiopathic short stature?
Idiopathic short stature is actually a diagnosis of exclusion. When you exclude all causes of short stature, including growth hormone deficiency, and you don't get any cause, and there is no familiar short stature also, then only you label it as idiopathic short stature.
And the role of growth hormone role of growth hormone?
So idiopathic short stature is now a licensed indication for growth hormone therapy, but the problem is the outcome is not as good as GST. The response is not good.
Tell us about long-acting growth hormone. Already you have told.
Yeah, already we discussed. So it is a new molecule which is helping us, but I think we need more time to understand it better.
Any question from audience?
Thank you.
Thank you.
Thank you, sir, for such an enlightening talk. Now I request the chairperson and the speakers to proceed to the felicitation area. Coming to the third session of today on gastroenterology, when diarrhea is non-infective. I invite Dr. Vibhor Borkar sir to educate us on this very important talk. And to chair this session, we have with us Dr. Bhushan Mirje sir, the pediatric gastroenterologist and assistant professor at CPR Hospital, Kolhapur, and Dr. Prashant Patil sir, practicing pediatrician from Islampur. We welcome you, sir.
Yeah, thank you. Good morning, everyone. And I will like to thank Kolhapur Indian Pediatrics Academy.
One minute, sir. I will like to introduce Dr. Vibhor Borkar, sir. He is presently working as Director, Pediatric Hepatology and Gastroenterology, Center of Liver, Intestine and Pancreatic Transplant at Nanavati Max Super Specialty Hospital. Sir is first DM Pediatric Gastroenterologist in Maharashtra. Also, he is very renowned for his work in Pediatric Gastroenterology. Now, I would like to hand over mic to the sir.
Yeah, thank you, sir, for the kind introduction. So, I will like to thank Academy of Pediatrics Kolhapur for giving me opportunity to give a talk on this topic. That's when diarrhea is not infective. Now, let's proceed to the session. So, we'll start with the case. Now, this is very typical case that we see in our day-to-day life. So, we have around a 4-year-old kid who presented for 1.5 years. This child is having a diarrhea, where stools around 4 to 5 to 6 per day is large quantity. There is no features of colitis, so there is no blood in the stool, there is no fever, child never had a dehydration, but there was some abdominal distension, flatulence and the foul smelling stool were there. And this diarrhea started right from somewhere, probably weaning was started around after 6 months, and then the diarrhea started. So then along with that, the child has a growth failure, has a refractory iron deficiency, anemia. On evaluation, his weight and height percentiles were low. There was a loss of subcutaneous fat, pallor, abdominal distension. Now this is the case. Now how we should proceed? Now let's revisit certain definitions. Like we know that when we call diarrhea, we call the chronic when it is more than 2 weeks, and we call persistent when it is an acute onset that persists more than 2 weeks. And intractable diarrhea of infancy when it starts less than 3 months of age and quite severe and might need parenteral nutrition. And protracted diarrhea, basically they are kind of an acute diarrhea which lasts for longer duration, but irrespective of the severity, they resolve. Okay. So now these are the common causes of chronic diarrhea. This is from any textbook. The ones which are highlighted are the non-infective causes, which is our today's interest of discussion. So if you see the younger age, probably the milk protein allergy, immunodeficiencies, these are the one on the top. As we go on the older age group, probably that in toddlers, celiac disease, again food protein allergies of a non-infective one are common. And older children, of course, irritable bowel syndrome, celiac disease, inflammatory bowel disease, these are the common causes. Now let's see. When you have a child with a chronic diarrhea, how to approach it? Now first the question will be, are we dealing with diarrhea? And if yes, then what is the type of diarrhea and what can be etiology? That's how we will assess it. So we'll see once we know that, okay, it's a chronic diarrhea, we just saw the definition that is lasting more than 2 weeks. Then we'll see what kind of diarrhea, what kind of, basically anatomically, where is the location? Am I dealing with something which is originating from small bowel or something which is originating from the large bowel, or is a mix of both? Then over the secretions, whether it is an osmotic type of output, whether it is a secretory type of output, or it has both the pathologies. Then what's causing the diarrhea? It is a maldigestion, malabsorption. Then associated features, anemia, weight loss, rash, other systemic involvement. And then after this, well, then we come narrow down to the etiology. Now these terminologies may be sounding difficult, but they are very helpful when you are approaching a child clinically, because that helps us to narrow down our differential diagnosis, select appropriate investigation, come to the diagnosis quickly with minimum possible cost. So that's why the clinical approach for any, whatever the advances we are dealing with, the clinical approach will never ever go. And it's more important for the students if they are here. Okay, now coming to the, like when you are dealing with the gut, so when you are saying about diarrhea, so it's not only the small and large intestine, also think of a liver and pancreas. So these 4 organs generally constitute to the diarrhea which lasts for longer duration. So think of these 2 organs also. Now, if we try to understand the physiology, there are various phases of digestion. One is the luminal phase, digestion at the mucosal level, and then post-mucosal phase. What do you mean by the luminal phase is, we have eaten something, like starch, proteins, and a large chain triglyceride, they are broken down to the simpler molecules. So that is basically the luminal phase of digestion, which has been taken care by the pancreatic enzymes and bile salts and pepsinogen from the stomach. So this we call as a mild digestion. Prototype is cystic fibrosis or any pancreatic insufficiency. Now mucosal level means the enterocyte level problem. So where what happens there, once from the first phase they are broken down to the smaller molecules, they are absorbed. Glucose absorption, galactose absorption, tripeptide absorption, and the micelle formation, that's taken care of the bile acid. So when there is a problem with the mucosal level, we get the malabsorption kind of diarrhea or food intolerance. So prototype is celiac disease. When you have a problem in the post-mucosal level, we get basically, so this is a lymphatic delivery system which is ideally get obstructed or destroyed by the various process, where we get a lymphangiectasis kind of a presentation. So this basic concepts is important when we are dealing with the chronic diarrheas or non-infective diarrheas. Now there can be another way also you can classify them, like acute, chronic, volume wise, pathophysiology wise, watery, steatory, inflammatory, or bowel which is small or large. Okay, so now again coming back to the malabsorption and maldigestion. How to clinically come to a conclusion what we are dealing with. So we know that the maldigestion mainly will be, so the fat maldigestion will be predominant because mainly the pancreas is takes part in. So you'll get a lot of steatorrhea, and in the stool volume will be not that high, and there will be intact triglycerides and they do not have any irritant effect. So that's why they are just, the frequency of it doesn't go up. But when it is a malabsorption at the mucosal level, you get fat malabsorption, you can get the protein malabsorption, you get the another anemia, hypoalbuminemia, and the stool volume, it has some watery component because of the irritant action of the free fatty acid, because your fat has broken down to the fatty acid and the glycerol. So that's how the malabsorption, the diarrhea is more dramatic compared to maldigestion. Okay, how do you know the localization to the different segments? So if you have a small bowel diarrhea, the volume will be large, and generally there will be a steatorrhea. Because of carbohydrate malabsorption, the stool will be explosive. In the infants, you get a perianal rash. Protein malabsorption will be there, and there will be foul smelling. Pain may be there, and the color of the stool is pale because of the large volume. And there will be a frequent nutrient deficiencies, because small bowel is the important part that takes care of the nutrient absorption. Now large bowel, mainly the cause is the water absorption. So the stool volume still it's small if it is more of a distal involvement. Blood might be generally present if it is in a colitis, but the other micronutrient deficiencies you don't get. Okay, and generally you can get sometimes anemia and nutrient deficiency because of the blood loss, but it is not as prevalent as we get in a small bowel diarrhea. Now how to know about the osmotic and secretory component? Practically you get generally the mix, you never get that basically a watershed line where we can differentiate between the two. But generally in osmotic clinically, more important is that there can be a perianal redness because of the acidity of the stool. Then watery stools are explosive, there are a lot of gas. It responds to the fasting. The book says 48 hours, but even 24-hour fasting is essential. The diarrhea output decreased to less than 50%. Now, these are the biochemical parameters which generally difficult to do it, but your stool pH is less than 5, reducing substances are positive, but they are very non-specific. Even in the secretory diarrhea also you can get it. So, most important is the clinical approach when you are differentiating osmotic and the secretory diarrhea. Now, so this is like about the diarrhea component, but again we should again ask the other important histories, like how's the feeding history, any relation to the change in the diet, any blood, any other extra intestinal features, any growth issues, family history, and vitamin other deficiencies that we already discussed as a part of a maldigestion. What is the food, if there is any milk, when the milk was given, any addition of the sugar, ORS preparation was adequate or not. So all this history is important, and that helps us in coming to a conclusion. Now, revisiting our case that we discussed in the first initial slide. So this is the case. Now let's see. Child has chronic diarrhea? Yes. Has a small bowel type of diarrhea because of the growth failure, iron deficiency anemia, abdominal distension. Now with this malabsorption, yes, because again there are lot of deficiencies are there. And it is osmotic type of diarrhea because there's a large volume, and after feeding this child, as though this was not mentioned over here. So this child has basically a malabsorption kind of diarrhea. So how to approach? So once you have a child with chronic diarrhea, you see, are there any red flags, which means weight loss, extra GI manifestations and deficiency. If there are none, then you think of either a toddler's diarrhea in a younger kid, or irritable bowel syndrome, which may be a diarrheal predominant or mixed variety. But if there are any red flag sign, you see, can you observe for some certain period? If yes, you try dietary interventions. Younger kid, try with the milk-free diet. Older kids, maybe in antibiotics or lactose-free diet if there is a secondary lactose deficiency. But if you think no, you cannot wait, then this child need a detailed evaluation. So what does it mean? So you have to approach stepwise. So there are different steps. I'll just mention briefly. So first you go with the non-invasive test, stool analysis, serologies. If you had a availability, then breath hydrogen test, stool calculating now available, immunodeficiency. So you take a clue from the history. It's not that you have to do this in all the cases. Once this is done, you look for the mucosa. How is the mucosa? Is the mucosa, if suppose I'm at this stage, I'm thinking it is a maldigestion, I will not do scopy, I'll go for the cross-sectional imaging. But I'm thinking it's a mucosal pathology, I'll go for the endoscopy. So I can go for endoscopy, look for the histopathology, like the lining, how is the lining, how is the infiltrate, how is the damage, and what kind of the cellular infiltrate the mucosa has. And then we go for a more specific one, we leave it now. Now step 3. So now in the present, so this is just the step 1, we do all the stool tests, we are aware of it, I'll not go in the detail. Then investigation wise, so this is important specifically for the students, sorry. So how the investigations can give clue to the different diagnoses. So anemia, okay, most of this is small chronic diarrheas will have deficiencies. But you look for whether it is just iron deficiency anemia, or you are getting the dimorphic along with then vitamin B12. If it's a B12 you are getting, think of an ileal pathology. So it can be an IBD also. Lymphocytopenia, link for the lymphangiectasia. Neutropenia can be Schaumann-Diamond syndrome. So if you have both, so sometimes you are getting the diarrhea with anasarca. So look for, if there is only albumin is less, then I'll think of a renal pathology. But if both total protein and albumin is less, I'll think of more of a GI pathology first, because it's the total protein loss. So that will give to the clue to the protein losing enteropathy even in the absence of diarrhea. So that's how this basic investigations basically open a window to the further diagnosis. Then again, there's a list of non-invasive tests. I'll not go in all the details of this, but again, this gives us a clue. Then next is the intestinal morphometry. So you can have a biopsies from duodenal mucosa, ileal and colonic mucosa, and you do the staining. And if required, one can do a cross-sectional imaging. now in this test, so in this child we did the serological test, and the utility of serological test is basically it generally aids in the diagnosis, it doesn't confirm the diagnosis. So in this child there was actually a scalloping was present and there was a severe villous atrophy that basically clinches the diagnosis of a celiac disease. So then appropriate treatment was started. So in India, though your TTG is positive, the celiac disease diagnosis will be done on the basis, we should be doing on the basis of confirming the changes in the small bowel or duodenum. That is most important. Now let's see a similar case. Now again, this is again the 4 years boy, similar age, loose stool for an year, stool frequency 5 to 6 times, nocturnal symptoms, mild abdominal distension, but greasy stool, malodorous stool. So greasy means fat, malodorous means probably a protein also is not getting digested, and there was no any extra GI manifestation. There were occasional mild cough as not gaining weight and height, and on examination he was a thin built, apart from nothing significant, and the other examination, chest examination was unremarkable. So this child has a chronic diarrhea, red flags as a weight loss, small bowel or large bowel, of course small, osmotic secretory, probably it was mixed, maldigestion, absorption. I think maldigestion was more in this child, associated symptoms, weight loss and pallor. So that's how we analyze the case. Now when we did the workup, this child has anemia, then the rest of the workup was unremarkable except TTG was positive, 86, normal was 5, so it was more than 10. So, and IgA was normal. We should always do an IgA, rule out IgA deficiency before interpreting TTG test. Now with this child was diagnosed as a celiac disease. Are you okay with this or not? Yeah, so biopsy was not done. So the 86, the child, so the gluten-free diet was given, multivitamin, calcium, iron supplements, everything was given. But however, after 3 months, there was only partial improvement. So all the improvement was just because of the good nutrition. Diarrhea persisted, weight loss, weight and height, no significant improvement. So now what to do in such cases? We should always review the diagnosis. Already now, if I do the biopsy, I may not get all the changes because that opportunity is already lost. So I asked for a strict gluten-free diet. There was no response. Then gluten challenge was given to the patient, and we again repeated TTG. Now after giving a good wheat also, the TTG is not impressively high. It's not normal but not impressively high. This is a false positive TTG, which can be seen in many other diarrhea. That's why in Indian situation, even the many infections can give you a false positive serology. So biopsy is must. Then I did an ogidoscopy, day 2 biopsy, both normal. So now what? Then cross-sectional imaging, we have seen 4 organs which are involved: large bowel, small bowel, pancreas, biliary system. So this is a sclerosing cholangitis this child had. Pancreas, the PD is not seen over here, and this child also had a bronchiectasis, which is a subtle. This is a cystic fibrosis confirmed on the genetics. So this is a cystic fibrosis where presented as a chronic diarrhea, TTG was positive, and probably missed for 3 years. So that's why and if you see the clinically also, the approach, the possibility was more towards the maldigestion rather than the malabsorption. That's why the clinical approach is important, whatever the labs you have. Now quickly going through a few cases more. So this is an 18-month-old boy. Now this child, the family went to a destination wedding somewhere, and after that this child started having diarrhea, which is going on for 6 weeks. Initially more, then decreased but persistent. Otherwise, this child was managed at home. No dehydration, blood in stool, no fever, no GI manifestation, no weight loss. Mother says he has decreased food intake, and they stopped milk intake for 2 weeks, but there is no improvement. On examination, absolutely okay. Child is sitting, all antibiotics he's received, ORS is getting. So how to approach? So this was okay. Anthropometry. Aniket must be wondering why I am not showing this. Okay, so coming back to our algorithm. So where are we? Do we have red flags here? No. So probably I am somewhere here. Go back to the history. This child was taking 6 packets of ORS daily. I thought he might be taking those 200 ml Tetra packs, but they were that whole pouch which is dissolved in a 1 liter. So 6 liter of ORS this child was taking because he has diarrhea, and he was liking the ORS very well. But for the sweet taste, very odd kid, but it was a osmotic diarrhea for 6 weeks he was taking, and I just did the electrolyte to see whether he has any hypernatremia. Fortunately, was not. This is, you can see, just 2 days prior test is there. Child improved. This is, I think, 4th or 5th day of his presentation. Immediately, in 48 hours, osmotic diarrhea will improve. Okay. So again, going back to the clinical history is very, very important. Clinical approach. Otherwise, we will land up with 1 month or 6 weeks diarrhea. We'll do a lot of tests, OGD, colonoscopy, stool calprotectin, not required. Good clinical history. That is the basis of approaching any clinical case. Is what are the specialty tests. Now, quickly I'll go through the last case. 12 years old boy. He had initially a constipation, pain in abdomen. Then started coming. This was the colicky, and now for the last 1 year he has the pain increase. Where they were probably interpreting it might be because of constipation. Then he started diarrhea, which was a small bowel type. There was no colitis. Intermittently, there was vomiting. And now he started losing weight for last few months. He lost 2 kgs of weight. So if you see his centiles, so he had height of a lower centiles, weight of a lower centiles. BMI was low, height was okay. And on examination, there was some diffuse fullness on the left side. So we have now here the child with diarrhea, he has a pain in abdomen and some mass and weight loss, some fullness, not a mass. So this is probably a subacute kind of thing, subacute intestinal obstruction, which can have a diarrhea because of a small intestinal bacterial growth or the primary etiology. So the prototype cases over here are, like, we should think of tuberculosis, you think of Crohn's, lymphoma, or eosinophilic enteropathy. It can be an allergic phenomenon as well, where there can be a mass of eosinophils. Now, so the workup was done elsewhere, where they find that OGD-scopy and colonoscopy and the biopsies were absolutely normal. So then how should we proceed further? So we did a CT. Now the CT shows that the jejunum has a thickening. So then what will you do? How will you reach there? So should we start ATT? Laparoscopy. Okay, yeah, laparoscopy you can do, but it will be then full thickness. That will be a hole in the intestine. And it's a big child. What can be done? So what we did is, capsule will get stuck. Capsule is a contraindication in such case because you cannot get a histopathology. There is a narrowing and your capsule will get stuck. So what we did is we did a double balloon endoscopy. So double balloon endoscopy is, so there is a normal scope and there are 2 balloons at the tip and there is an overslew. जसं आपण हे नाडा टाकतो ना, the same way the scope goes in and we can see the entire intestine. So any small bowel obstruction of a child who is more than 18 to 20 kg, we can scan the entire intestine. So we managed to reach over here. So there was a stricture, there was an ulcer. We took the biopsies. The biopsy was suggestive of a IBD. There was no lymphoma, there was no TB. All the workup from the gene expert, MTB culture was negative from this one. And we started this child initially with the diet, exclusive enteral nutrition. He improved, but it is a stricture because a long-standing disease, already late when he presented to us. So we have to do a surgical resection, and after surgical and end-to-end anastomosis, so after that he improved. And because he had a stricturing disease, he was on biologicals, and then after an year of biologicals, it was stopped. He's just on immunomodulator and doing well. So in nutshell, when you are thinking of an inflammatory bowel disease, first thing, this child has a classical triad of a pain in abdomen, diarrhea, and anemia and weight loss. So when you get this classical triad, this is a small intestinal Crohn's disease, and we are seeing, I think this is a 3rd or 4th case like this, where your OGD colon was normal, and on double balloon we could diagnose the small intestinal Crohn's disease, and these cases are there in our population also. So important is we have a high index of clinical suspicion, look for extra GI manifestation, look for the labs suggest any inflammatory one, and then you have an endoscopy, you have a CT radiology, which can be a CT, MR enterography, barium, or even now bowel ultrasounds. Even non-invisively bowel ultrasounds can be done. Take the biopsies, rule out tuberculosis, and also whole exome sequencing is required. Okay, this is just a nutshell management of an IBD, but take care of the nutrition, take care of the bone health, growth and puberty, and optimize immunization. These are the other aspects also we should look when you are managing the child with diarrhea. Okay, so thank you. So this is the last slide. Any questions? Yeah, thank you.
Thank you, sir. Actually, chronic diarrhea is a very big topic. So, covering in such a short time, it's very difficult. But sir has covered maximum points and important clinical scenarios which we commonly see in a day-to-day practice. So, take home is a clinical. I think still clinical suspicious is a very gut. For GIT, is a gut feeling is matters. So I think whatever your gut feeling, you stick to the guts and try to confirm the diagnosis by with the help of such a investigations. Lots of investigation modalities are available, so we can reach the diagnosis and we can treat the patient if we confirm the diagnosis. Yes. Yeah. Thank you, sir.
Yeah. Thank you.
Sir.
Yeah, please.
What is the role of probiotics in acute infective diarrhea?
So I think there is a good meta-analysis are there, and so the role is to decrease the duration of the diarrhea. There is nowhere it has been, all the studies have showed that it decreases dehydration and it improves mortality. So you see, what is your question in treating the patient?
So, but when there is gut injury and we are giving live bacilli, like there is no further complication that we can create, right?
Yeah, no, because already gut has so many live bacteria which are already there. They are already there. So all these one are the lab tested one where they are not the pathogenic one. So that is the prerequisite by selecting a probiotic. There are non-pathogenic bacteria. So they are not going to cause a harm apart from patients who are immunodeficient. So all immunodeficient patients are contraindicated. So we don't give an immunodeficient patient. All those patients, the post-transplant, we don't give. But otherwise, other acute diarrhea, normal child, there is no harm. As I said, it may decrease the duration by 12 hours to 24 hours. That is the only thing. So you may save from 5 to 6 diapers cost to the family. It doesn't help in decreasing the dehydration, doesn't decrease the mortality. So you should know what question, like what benefit you want to give to the patient and from what social strata the patient is coming. If they are very poor, why to spend on the probiotic? But if you think they are from, yes, they can spend, yes, please give it. Okay.
Thank you, sir.
Yeah. Yes, sir. So it's very common. So there are different systems are different, like liver manifestation, like sclerosing cholangitis, autoimmune, we get around 2%, joints one around 10%, growth is almost affected in 30 to 40% depending on their presentation. Even episcleritis, and again we see in 2 to 5%. So again the skin manifestations like erythema nodosum, again 2 to 3% of the patients we are seeing. So they are there. Oral ulcers, again very common, around 40 to 50% we get oral ulcers. So it can precede the IBD by 2 years also. Means you can count only arthritis and no IBD symptoms. So you have to be, so suppose your arthritis is not responding to the common treatment by a rheumatologist, think of IBD as a cause, look for the other possibilities, and generally it is associated with the disease activity. Once we treat the disease activity, the joint swelling goes. Good point in over here, they are not deforming arthritis. Permanent. So whatever this, they are functionally they are well after that. So generally 4 weeks time and all, there is a significant improvement in the pain and in the this.
Thank you, sir.
Thank you. Yeah, so that's why I showed you the algorithm. So if there are no red flags, you can wait and assess. If there are the red flags, you can do some, if there are, suppose you think there are red flags and patient is stable, you can apply the clinical algorithm. You see if your dietary intervention can help, whether it is just after maybe an infection, there can be lactose intolerance. On an infant, you think is a milk protein allergy. You can do some intervention. Maybe you can wait for 2 weeks or so. But after that, suppose your child is not responding, then after 2 to 4 weeks, rather than keep on trying different antibiotics, you should refer to a ped gastroenterologist and evaluate and see what we are dealing with. Because growth is important. Whatever the months lost of the growth, they may not regain all the centiles. Yes, sir.
Sir, actually, I have one patient who is 2 years and 5 months female. There is history of 3 times episodes of loose motions for which she was treated by the mother at home herself. Only once she required admission, but her growth is like at 2 years and 5 months, her weight is only 9.9 kg. She has anemia, but the most striking fact which we found yesterday was platelet was 11 lakh and 98,000. Which was quite surprising, so we repeated it again. The stool report is suggestive of lot of mucus, RBCs, multiple macrophages and pus cells abundant. So in this scenario, even though there is not that much history of like chronic diarrhea per se, only 3 days history, should I be looking for any like malabsorption or maldigestion type of disorder?
So here your anemia is there, platelets are high, so this is an acute phase reactant. So you are dealing with some inflammatory etiology and it's a longer duration. You said weight has not gained, but also you should look at the height, and yes, this child should be evaluated if they are persistent for longer duration. The mean symptom onset to diagnosis for inflammatory bowel disease was 3 years to 3.5 years, even in the developed countries around a decade prior. Now also it has not much change. So in India also you have a delayed diagnosis of 2 years. So earlier referral is better. There is no harm in referring. Yeah.
Thank you, sir.
Yeah. Thank you.
Thank you, chairpersons. I request all the dignitaries to proceed to the felicitation area. We have a slight change in the sessions. We are skipping to the next one. The next session is Epilepsy Chronicles, Unraveling Compelling Cases, which will be given by Dr. Jaishankar Kaushik sir and will be chaired by Dr. Anil Kurne sir and Dr. Rahul Patil sir. Dr. Anil Kurne sir is senior pediatrician and professor at BKL Valavarkar Medical College, Chiprun, and Dr. Rahul Patil sir is practicing neurologist in Kolhapur and also secretary.
Dr. Jaishankar Kaushik is an excellent pediatric neurologist from precious AIMS Institute, Guwahati, with more than 100 publications which are indexed in journals. He has contribution in the pediatric neurology clinical textbook. He has done his DM from AIMS Delhi. This is very short introduction. Over to Jaishankar Kaushik.
Thank you very much, sir. Wish you all a good morning, and I thank the organizers, especially Dr. Rahul, for inviting me to the city of Kolhapur. In the next around 25 minutes, we'll grossly cover a few common conditions that we tend to encounter. So the main learning objective of this session will be to develop a basic approach to a child with a seizure or an epilepsy through few case scenarios, and to also understand the plan for investigating a child with seizures or epilepsy through these case scenarios, and also try to understand and develop a rational management of these seizures and epilepsy. So I'll start with this 2.5-year-old girl who presented with multiple paroxysmal episodes of these abnormal movements which have been there for the last 3 to 4 months. So the child was started again on multiple anti-seizure medication, and the mother typically says that the child comes back to the home and she will have these kind of a grinding movements of the thigh, which continues for a very long period of the time, and if you try to distract her, she will get really very irritated. So do you think it's an epilepsy? Yes, wonderful. So it's a self-gratification disorder. So we need to identify that this is not an epilepsy condition. So anything that happens, multiple and paroxysmum is not equal to epilepsy. And we should remember that such diagnoses are usually made clinically, and often EEG is not even required in these children. So this is another child who presented, two similar cases who presented with a similar kind of a condition, multiple episodes of these paroxysms that keep happening, and it looks as if somebody has, poured a cold water on the child's this thing. So the child shivers like this, and this is how the other child also starts shivering. And these are multiple episodes and otherwise typically developing children. Do you think it's again an epilepsy? Do you think it's a seizure? Probably correct. So these are very clearly a shuddering spells. So these shuddering spells need no EEG, no investigation, and it is purely a clinical diagnosis. This is another 10-year-old girl who presented with multiple episodes of these abnormal movements. 15 to 20 episodes happen per day. And this has been there for the last 10 days. Somebody got an EEG, somebody got an MRI also done, and you can actually notice that these episodes are very non-stereotypical. That means every time it changes a little bit, and she holds the hand and it is distractible. So multiple such episodes in a day, an adolescent girl, something which is again recent onset with all investigations also being normal. Do we again think it's an epilepsy? Probably not. So these are probably paroxysmal non-epileptic events, which are also called as PNES. Again, this requires only and only video-based clinical diagnosis that's there. This is another 18-month-old baby who again presented with these multiple paroxysmal episodes. The mother typically says that in each episode, I feel as if I have just lost my child for a minute. And this is a very classical feature which the mother will often try to say, that I felt that I lost the child and I actually started resuscitating the child. And you can actually look at the child. It really looks really very scary to have such multiple episodes in a day. So somebody thought it is a seizure, again got an EEG, again got MRI, everything totally normal. So what do you think the child is having? Somebody who has these multiple paroxysmal episodes, and in each episode the pallor, that is a very characteristic feature that happens. So what could this condition again be? These are again pallid spells, or they are again breath holding spells, which are breath holding or pallid spells. And one of the characteristic feature which I wanted to emphasize is that you ask the mother that did you feel that the child was lost? You will never see this kind of a history in a typical seizure history. So if the mother says that yes, I felt I lost the child, this is something which is again a very classical history of a pallid spell. This is another 11-year-old boy who had these multiple episodes in which the child was perfectly fine, and again the child has these kind of abnormal querying movements, and these abnormal movements often get triggered when he suddenly gets up, suddenly sits down, and again these are around 15 to 20 episodes in a day. And somebody started this child on multiple anti-seizure medication, nothing helped, and some wise man started this child on carbamazepine, and every episode disappeared. So what do you think this condition could be? Yeah, so these are dyskinesias, in which you can notice that the child was having dyskinetic movements. These were paroxysmal. That means it had an abrupt onset, abrupt offset, multiple such episodes, and these were kinesogenic. That means something triggered and then the dyskinesia happens. So these were very classical paroxysmal kinesogenic dyskinesias, which is, although a non-epileptic condition, it is known that carbamazepine tends to work very, very well. So what we need to understand is that through these scenarios, that first we need to recognize, is it actually a true seizure or is it not a seizure? If it is not a true seizure, or if you are in a doubt, please do not get an EEG done to be sure whether it is a seizure or not seizure. Ask the patient to make a video. Try to fit it into some known kind of a non-epileptic event, like a shuddering spell, like a gratification, like a non-paroxysmal dyskinesia. Counsel the parent parents do not get an EEG to prove that it is a non-epileptic event. It's not a very good practice, because many of the time you will realize that the EEG is often reported in a erratic manner, and many of the time you land up in treating these children based on the EEG report. So what I wanted to convey is that do not start anti-seizure medication and see what happens with these kind of a condition. So through these scenarios, I have tried to highlight that anything that is multiple paroxysmal episodes, they are all not always epileptic event. Try to recognize them. This is another 3-year-old boy who presented with 2 episodes of abnormal blinking movement of the eyes. The second episode lasted almost for 40 minutes. The child was brought convulsing to the casualty. This episode was followed by a very high-grade fever. This is a 3-year-old boy. There is a family history of febrile seizure in the elder sister. There are no meningeal signs as such. So this child presented with a prolonged seizure followed by fever with a family history of febrile seizure, no meningeal sign. The child regained consciousness immediately. So will you do an LP in this child? Probably if there are no meningeal signs, a big child, the child is conscious, you will not think of getting a... so will you do an MRI in this child? A child who had a prolonged seizure followed by a fever, and the child has presented to you, you thought it could be a febrile seizure, but again now you are seeing that the episode was prolonged. So this was a febrile status epilepticus. So whenever we are encountering a children, out of all simple febrile seizures, and simple febrile seizure definitely does not require any of these investigation, but among the complex febrile seizure, please do recognize children with febrile status epilepticus, because many of these children will have hippocampal changes due to which they will ultimately go on to develop epilepsy. So please recognize children with febrile status epilepticus who definitely require MRI, who definitely require EEG, and yes, if the child is from a very distant place where you think that it will take a very long time for the child to come to your center, so do consider starting anti-seizure medication. Out of all complex febrile seizure, please recognize febrile status epilepticus. And also an important message that I wanted to give through this scenario is that it's quite possible that the child has fever after the child developed the seizure. Febrile seizure does not always have to mean that the fever has to precede a seizure which is there. So now this is another child with a similar kind of a scenario, who is a 7-year-old boy with fever and seizure, but now the seizure is for 20 minutes. It's a very typical generalized seizure, no family history of epilepsy or febrile seizure. So will you get an MRI done for this child? But it's a simple febrile seizure. 20 minutes, it's okay, 15 to 20. We call it as something febrile status epilepticus as something more than 30 minutes. Wonderful. So is there anything other than that that makes you feel wrong? Wonderful. So please recognize that children beyond 6 years of age presenting for the first time with a febrile seizure, don't take it on a lighter note. So it's very, very important that such children often get a label of what is called FS plus, that is febrile seizure plus. So please recognize these conditions. So through these 2 case scenarios, I am trying to emphasize that these are the 2 group of the children who will require imaging. They are the group of children who will require EEG, and they are the only group of the children who will require anti-seizure medication. So it's very, very important to recognize febrile status epilepticus, which definitely requires continuous prophylaxis. And if at all you think of continuous prophylaxis, please do consider sodium valproate. Do not consider children to be started with any other anti-seizure medication, especially phenytoin, carbamazepine, all of them are completely contraindicated in such condition. So moving on to another child who is a 1-year-old boy who presented with fever, seizure and altered sensorium, no focal deficit on examination. LP was suggestive of pyomeningitis. You loaded the child with phenytoin, maintenance 5 mg per kg you started. How will you taper this anti-seizure medication? Now the child is totally fine. You have treated the meningitis with antibiotics. So how will you taper this anti-seizure medication, phenytoin? Wonderful. So something which is symptomatic seizure, something that is a seizure that starts because of one episode, that is meningitis. These are all symptomatic seizures. They are not epilepsy. So they do not require long-term anti-epileptic medication, and they also do not require any EEG before getting before tapering it. So another similar scenario, 10-year-old, 10-month baby fell down from the first floor followed by one episode of a seizure. No focal deficit, sensorium totally normal. Neurosurgeon opined that you start the child on phenytoin. He got an NCCT done, absolutely normal. What will you do for this child? Will you taper the phenytoin? Yes. If the neuroimaging is totally normal, the child does not have any neurological deficit, the child is neurologically fine, nothing beyond 7 days is usually required in such conditions. So do not consider, continue this phenytoin, and you might often not require EEG to document before you taper it. This is another scenario in which a 10-year-old boy who presented with the first episode of a focal seizure, the EEG at admission showed a focal slowing. The parents, the doctor gave him albendazole for 28 days under the cover of steroid with phenytoin. So in such a scenario, when will you taper phenytoin? We will have to continue. What we usually do is that we get a repeat neuroimaging after a duration of say 6 to 12 months. If the repeat imaging is completely showing disappearance of the neurocystic then it is still okay that you document an EEG and start tapering. But agar wo repeat imaging में calcify हो जाता है वो neurocystic sarcosis, so these are the group of children who will ultimately require anti-seizure medication to be continued for 2 years, and at the end of the 2 years get an EEG documented, and if the EEG is normal, start tapering the anti-seizure medication. So despite this being an acute symptomatic seizures, please do consider continuing anti-seizure medication, because predominantly 90% of these children will ultimately develop calcified neurocystic sarcosis, as in this child who had a repeat imaging which showed calcified this thing. So what I wanted to convey was that please recognize children with acute symptomatic and remote symptomatic seizures. Acute symptomatic seizures and remote symptomatic seizures need to be recognized. Similarly, recognize children with provoked seizure in which the provoking factor like head trauma, like the scenario that we saw with meningitis, once that provoking factor is getting treated, they are usually not an epilepsy, so they do not require long-term anti-epileptic medication. So in such scenarios, look for 3 important things: presence of focal deficit, presence of encephalopathy, presence of focal cortical signs. On the imaging, they will decide on the duration of anti-seizure medication. So now moving on to from the non-epileptic conditions and symptomatic seizures, we move on to epilepsy syndromes, and we know that broadly that this is the recent classification by which we have divided them into self-limited epilepsies, developmental and epileptic encephalopathy, and the genetic based or the etiology specific kind of a epilepsy syndrome. So these are the type of the classification that we tend to use. Now let's see this 2-month-old baby who presented with excessive crying, irritability for the last 10 days. The child was on phenobarbital and phenytoin at the dose of 7 mg per kg. So this is the child who had these multiple such episodes in which the child had these kind of sudden jerks which were happening. So what do you want to think? The child is already on phenobarbital at 4, phenytoin at 7, nothing is helping the baby. Yes, wonderful, sir. So this is a very typical epileptic spasms which were earlier called as infantile spasms, and this we got an EEG done, and EEG classically revealed a classical hips arrhythmia. So we need to recognize children with epileptic spasms, because epileptic spasms, the characteristic feature of this epileptic spasm is that these jerks often happen once the child awakens from the sleep. और मदर टिपिकली कहती है कि बच्चा सो के उठता है, फिर उसके बाद उसको झटका लगता है, और जब एक बार झटका लगता है तो 5, 6, 10 बार इकट्ठा झटका लगता है. सो दैट मीन्स क्लस्टरिंग relation to sleep-wake cycle, and a little prolonged episodes, and many of them are associated with a crying or an autonomic manifestation. So if these three things are present, recognize epileptic spasms, and it is very important that phenytoin is not a good drug for epileptic spasm, and it might worsen these children. So it's very, very important to recognize these epileptic spasms. So this is another 8-month-old baby who presented with global developmental delay, not at all gaining any milestone, and multifocal epilepsy and hypotonia. And again you see, what do you see? Again, the child is having these kind of sudden jerks which are happening. The child is already on phenytoin and levetiracetam. Again, these are again sudden jerks that are typically happening in this child. So again, these are epileptic spasms that you need to recognize. So the important point that I wanted to convey is that epileptic spasms often happen in cluster. They occur on awakening from sleep. They are more prolonged than myoclonus. EEG often reveals hypsarrhythmia. Please give a strict no to phenytoin in such cases. Steroids are often indicated. Prednisolone at a dose of 4 mg per kg is a very good drug. As a second line drug, we often give vigabatrin, topiramate, and certain dietary therapies are also recommended for epileptic spasms. So this is few more case scenarios. 4-day-old neonate presented with an episode of convulsion, totally uneventful neonatal period. On day 4, the child had a seizure. EEG revealed mild background slowing, well controlled on phenobarbital. So this was earlier called as the 4th day or the 5th day convulsions, and now we call them as self-limited neonatal epilepsy, or it is also the newer terminology that we use is SELNE, that is self-limited neonatal epilepsy. They usually have a very good prognosis. So the general teaching says that something that starts very early in the neonatal period, they are usually not very bad kind of epilepsy. Something that starts at 10 years, 11 years are usually somebody who will ultimately go to the adult neurologist also. This is another 8-month-old baby with multiple episodes of sudden jerk, and again you see no clustering, no relation to sleep-wake cycle, and the most important thing is developmentally it is normal. Somebody thought it is epileptic spasm, got an EEG done. EEG just revealed a generalized spike wave but did not reveal hypsarrhythmia. And the most important thing is the child is developmentally normal. So it's very, very important to recognize that epileptic spasms, even myoclonic epilepsy of infancy, often looks like epileptic spasm, but the most important thing is developmentally the child is normal. Children with epileptic spasms usually will have a gloss developmental delay. Like in this child, this is a 10-month-old baby with multiple episodes of sudden jerk for the last 2 months, occurs more on the awakening from sleep, again in cluster, EEG showing classical hypsarrhythmia. So earlier we used to call them as West syndrome, now we call them as infantile epileptic spasm syndrome. So this is another scenario in which this is a 25-day-old baby. Usually epileptic spasms they usually start a little later, that is somewhere around 2 to 3 months. But if a 25-day-old baby starts having these kind of tonic seizures in which the child develops sudden tonic jerks which are there, and again the EEG shows almost like a burst suppression kind of a pattern, this is a very classical example of what is called as early infantile developmental epileptic encephalopathy. So this is very important condition to recognize, because these are the children who will require different kind of a therapy and they will require a different kind of a condition. So this is another epileptic syndrome in which a 2-year-old boy presented with multiple episodes of febrile seizures as well as afebrile seizure. Something started at 10 months of age, global developmental delay, the EEG showing multifocal kind of epileptiform discharges. So what do you think this could be? So we always try to make an effort that can this clinical syndrome and EEG feature, both of them match to form some kind of a syndrome. So this is a very classical Dravet syndrome. It's a Dravet syndrome. It's very important to recognize that these are the group of the syndromes in which we should avoid sodium channel blockers like phenytoin and carbamazepine. So I wanted to show you a few case scenarios of self-limited neonatal epilepsy. I have shown you a few conditions which are related to myoclonic epilepsy of infancy, developmental epileptic encephalopathy, infantile epileptic spasm syndrome, and Dravet syndrome. So this is a very classical example of other few epilepsy syndromes that you tend to encounter in your practice. School going, big child presenting with focal seizures, nocturnal, mother typically कहती है कि suddenly रो के उठता है बच्चा और उसके बाद suddenly एक जगह पे मुड़ जाता है and he has a speech arrest. So you get a sleep EEG done. This very classically shows the centrotemporal spikes, which was called as Rolandic epilepsy earlier. Now we call them as self-limited epilepsy with centrotemporal spikes. So this is another child who presented typically with, periods of the child being unresponsive for some period of the time, and EEG classically showing a 3 Hz spike wave pattern which is there. So this is a very classical syndrome of childhood absence epilepsy syndrome. This is another child who presented with, if you notice very carefully in his eyes, the moment he closes down the eyes, he has that fluttering myoclonia on the eyelid. So this is a very classical epilepsy with eyelid myoclonia, which you tend to encounter. And again, this is again a myoclonic, this thing in which you have a 3 Hz spike wave kind of a pattern. We need to recognize that EEG is very, very important supplement to reach any epileptic syndrome. So as compared to 3 Hz spike wave pattern, this is a child who had classical 5 to 6 Hz of this thing, and many of these children with juvenile myoclonic epilepsy will present with early morning myoclonus कि सुबह उठती है 11-12 साल की लड़की और चाय का कप सडनली टूट जाता है. So this is a very common history that you tend to see in children with juvenile myoclonic epilepsy. This is another very common syndrome that you tend to encounter in children, in which the child is intellectually disabled and has these tight episodes, tonic seizures, and the EEG is classically showing epileptic encephalopathy, and the child also has sudden jerks which are there. So this is a combination of intellectual disability, multiple types of seizures, and EEG showing epileptic encephalopathy. So this classically fits into Lennox-Gastaut syndrome. This is a very interesting child. This is a simple bedside test that you can do to trigger absence epilepsy, and the moment you try to do this thing, you can see that there is a shoulder shrugging which is happening, and again the corresponding EEG is showing 3 Hz spike wave pattern. So this is epilepsy with myoclonic absence. This is a very classical epilepsy syndrome that we tend to encounter. So that means we, over a period of the last 25 minutes, I've shown you few case scenarios of generalized epilepsy syndromes like juvenile myoclonic epilepsy, childhood absence epilepsy. We have also encountered few important conditions like self-limited epilepsy with centrotemporal spikes, which are also there. And we, as pediatricians, should at least recognize conditions which are developmental epileptic encephalopathy. Encephalopathy मतलब बच्चा grow नहीं कर रहा. वो क्यों नहीं grow कर रहा? क्योंकि there is a condition which is causing developmental delay, and in addition there is an epilepsy which is causing it. That's why it's called developmental epileptic encephalopathy. So 5 simple questions that can help pediatricians to reach any particular, whenever you're encountering a child, that is it actually a true seizure or not? Is it a provoked seizure or an unprovoked seizure? Try to identify the seizure type. Try to fit it into an epilepsy syndrome and see if there is some family history or not. Never forget the home management of children with seizure. Always advise them intranasal midazolam nasal spray. That's very, very important. And the last question that often comes to the mind is which medication should be chosen. Please remember that there is no anti-seizure which is better than another, but we generally tend to avoid valproate in suspected neurometabolic disorders, liver disease, obese, and in adolescent girls. We avoid levetiracetam in those with behavioral issues, and we tend to avoid phenytoin in adolescent girls, and we tend to avoid phenytoin and carbamazepine in children with idiopathic generalized epilepsy. So with this, I end my presentation by taking home the important points that please recognize, is it first a true seizure or not a seizure? Is it provoked? Is it not a provoked seizure? If it is unprovoked seizure, is it focal onset or a generalized onset? Try to fit it into some kind of an epilepsy syndrome. See if there is a developmental delay, is there a family history. Choose investigations judiciously. Do not order EEG for children with non-epileptic event, because you will land up in a soup when it reports, when clinically the history is like shuddering, but EEG is showing some kind of epileptic discharges. So choose the anti-seizure medication based on clinical diagnosis. So with this hope I did justice to the objectives of my presentation. So I thank all of you for the patient listening. So with blessings of my teacher, Dr. Piyush Gupta, we have written a book on clinical approach to pediatric neurology, and in another few days the second edition will come. This will be very useful and very written in a very simple language. So every pediatricians and pediatric residents might benefit from this textbook. So thank you very much for the patient listening.
Thank you. Thank you, Dr. Kaushik, for excellent cases and also describing treatment plan for different epilepsy syndromes. Thank you, Dr. Kaushik. Dr. Kaushik and I were batchmates during my PG training at UCMS and GTB hospital. So he is very sincere, and he has done DM from AIMS Delhi. I think he is second or third student of.
No, I have done later only, but.
Any questions to audience?
Thank you, sir.
Yes.
Very nice presentation, sir.
Thank
I
you.
just wanted to ask, in neonatal or infant age group, if patient has metabolic seizures because of prolonged hypoglycemia or prolonged hypercalcemia, what is the role of anti-epileptic drugs and what is the duration?
Yes, thank you for that question. Hypocalcemia is still okay. We will consider them as symptomatic seizure. We will, most of the time, once the underlying condition is treated by an endocrinologist like you, we will not start or we will not give anti-seizure medication. But hypoglycemia often leaves behind certain sequelae. So we are often not very, very comfortable removing the anti-seizure medication. Somebody who had a very bad prolonged hypoglycemia will tend to have structural changes in the occipital changes, which often ultimately develops into an epilepsy. So these are conditions where we often continue the phenobarbital for some point of time, but at the end of 1 month we assess clinically. If clinically the child is absolutely fine, we withdraw the anti-seizure medication, that is phenobarbital or levetiracetam that have started. But if there are some neurological deficit, early signs of cerebral palsy that we tend to encounter, we continue that till 3 months. Again at 3 months, we again re-evaluate the child clinically. Clinically अगर deficit है तो EEG करेंगे, और EEG अगर abnormal है तभी medication continue करेंगे, but if EEG is again normal, we withdraw. So the main objective is something that starts early, we try to remove it early.
Okay, so EEG we will not do in every case.
EEG is not usually recommended for deciding to start anti-seizure medication, but yes, for withdrawing if clinically the child has certain deficit. Otherwise, EEG has very, very limited role in deciding anti-seizure medication. But just one point that I wanted to add is that EEG is taking a major role in deciding whether it is a seizure or not a seizure in neonates, because subclinical or non-clinical subtle seizures are very much there. So now you will see that majority of the neonatologists will believe in not only looking at those subtle movements, but looking at the EEG also simultaneously.
Okay, so thank you very much.
Thank you.
Thank you.
Thank you, sir. Thank you, Chairperson.
Thank you.
I request all of them to proceed to the felicitation area. We'll next move on to Dr. Kamlakar Chitnis' oration.
Thank you. Now we shall proceed to the prestigious Dr. Kamlakar Chitnis' oration. organization are the result of combined effects of each individual, and the present day well organized, structured, inclusive Kolhapur Academy of Pediatrics is the effect of combined efforts of all pediatricians who laid strong foundation of this organization, and the pioneer being Dr. Kamlakar Chitnis. He was the first pediatrician in Kolhapur and an astute clinician. This oration is dedicated to Sir with love. Now I request Kolhapur Academy of Pediatrics President Dr. Sainath Pawar, Secretary Dr. Rahul Patil and Treasurer Dr. Prama Bafna to escort respected Dr. Sushil Kabra sir to the dais. I request the dignitaries on the dais to pay floral respects to Dr. Kamlakar Chitnis sir. Now we shall greet Dr. Sushil Kabra sir with traditional feta. Now may I request Dr. Rahul Patil to read the citation.
Respected sir, we at Kolhapur Academy of Pediatrics are extremely honored to have you sir, Dr. Sushil Kumar Kabra, for the prestigious Dr. Kamlakar Chitnis oration. Sir, your journey of 40 years in child healthcare has been exemplary. Your work in pediatric pulmonology and intensive care for more than 30 years is commendable. You started academic career as a senior resident, and by discipline you have achieved a position of esteemed faculty member, professor and HOD in pediatric pulmonology department at esteemed All India Institute of Medical Sciences, New Delhi. Currently, you hold the prestigious post of Professor, Division of Pediatric Pulmonology and Intensive Care, AIMS, New Delhi. Also, you are diplomat of the European Respiratory Society. You have been actively involved in the training of PG students, super specialty students and guiding them in research work. You are guide to 130 students pursuing MSc, MD, DM and PhD courses. Considering your vast experience, Central IIP appointed you as a member of core committee of RNTCP program. You serve as a core committee member for developing consensus guidelines for childhood tuberculosis, acute respiratory tract infection, COVID-19 infections. Because of depth of your work in pulmonary sciences, you are honored with a position in a committee for pulmonology fellowship by IIP. You possess a passion for transferring the core knowledge, and you have to your credit more than 900 guest lectures, 15 orations, more than 200 chapters in books. You authored the popular books like Essential Pediatric Pulmonology, Essentials of Tuberculosis in Children, AIMS PICU Protocol, Case-Based Review in Pediatric Pulmonology, which successfully ran in multiple editions. You continue to serve as member of the editorial advisory board of Indian Pediatrics, Indian Journal of Pediatrics, and Pediatric Infectious Disease Journal of IAP. Being a visionary leader, you started DM course in pediatric pulmonology and intensive care at All India Institute of Medical Sciences. You are a great organizer who has planned and executed excellent state and national level academic events very gracefully. You have contributed to various educational activities related to pulmonology and have conducted multiple workshops called AIMS Pediatric Pulmonology and Intensive Care course module, which has given knowledge to pediatricians all over India and abroad. Despite your challenging time schedule, you supervise, conduct, coordinate several national and international research projects. As someone has aptly quoted, a leader needs useful new information to flow, and leaders learn continuously. This drives you to take part in various research projects. You are principal investigator carrying out several research studies related to cystic fibrosis, asthma, childhood tuberculosis, and hemorrhagic dengue fever. You have indigenously developed low-cost method for sweat chloride estimation for diagnosis of cystic fibrosis. Among your finest achievements include developing a point-of-care diagnostic test for primary ciliary dyskinesia. You not only started interventional bronchoscopy and endobronchial ultrasound in children, but also developed PFT lab for performing tests in all age groups. You are the live example that being a mentor is not just a title or designation. It's about hard work, producing results, influencing students, and inspiring them to do good. In word of Henry Adams, a teacher affects eternity. He can never tell where his influence stops. We wish success for your vision for pediatric pulmonology care to outreach people. May your work be inspirational for generations of pediatricians to come. Personalities like you enrich the world. We as medical community are proud of your extraordinary work and salute you from bottom of our heart. And on this beautiful day of June 16, 2024, we request you to accept this token of gratitude from bottom of our heart. Thank you. Thank you, sir.
While the citation is presented by Dr. Sainath Pawar, let us give a huge round of applause and standing ovation.
Respected chairpersons and friends, I am really very grateful to Kolhapur Academy of Pediatrics for giving me opportunity to relate myself with Dr. Kamlakar Chitnis, a legendary pediatrician from Kolhapur. And I would like to share that I am one among you. I spent my 4 years of schooling in Maharashtra from 1968 to 72, 5th to 8th standard in Nanded. And so I feel myself related to Maharashtra. So in next 40-45 minutes, I'll discuss some cases which were managed by us, not by me, but by our team. And we try to make the diagnosis based on the clinical features, available imaging, innovations, and managing with available resources. And that I'll try to show you in some of the cases. So let us begin with some simplest but most common problem which we face in our day-to-day clinical practice. And that is a 3.5-year-old presented with cough, cold, and fever for 3 days, wheezing for 2 days, and there is a past history of suffering from cough and cold 4 times in past 6 months since he started going to school. And on examination, respiratory rate is 32 per minute, temperature is 100.2, and heart rate is 120 per minute. Chest is showing occasional wheezing, no chest indrawing, and rest of the systemic examination is within normal limit. So diagnosis of acute respiratory tract infection with wheezing was made and started on reassurance to the parents that he'll be all right. Paracetamol, salbutamol inhalation by MDI, and spacer SOS. And he recovered in 4 days. So this is not an uncommon thing. So acute respiratory infection is responsible for 20 to 40% of OPD and 12 to 35% of IPD attendance, and it depends on where you are working. And URTI is the commonest, upper respiratory is the commonest, 88%. And majority of the URTI are caused, say 90-95% are caused by viruses. And frequency of virus URTI may be varying between 3 to 8 per child in the first year itself. And we had a cohort of newborn. We were trying to see whether viral infection will lead to wheezing episodes later on. So we documented that each child had a 1.8 episode per year of ARI. So it seems that ARI will happen in every infant. In some infants, it is more frequent. Majority recovers without much interventions. But question is, when I should investigate further? So if it is a recurrent pneumonia, then it is a well-defined 2 episodes of clinical features of pneumonia in 1 year, or 3 episodes in any time frame documented with clinical features, recovery and X-ray abnormality. And persistent is 1 year, 1 month persistent symptoms with X-ray abnormality. So these children obviously will require a investigation. So LRTI will require an investigation. So if this is only a upper respiratory tract infection, when I should investigate? So red flags would be if there are extrapulmonary symptoms, failure to thrive. That is very important for a pediatrician to monitor growth. And if a child is failing to grow, it is red flag. And any condition, whether it is a ARI, whether it is a diarrhea, whether it is a febrile episodes, marked chronic upper airway symptoms like snoring, rhinitis, sinusitis, symptoms from the first day of life, episodes of severe persistent unusual pathogens which are recurrent, and that indicates whether I am dealing with a primary immune deficiency, chronic moist wet cough or sputum production, feeding problems. That is one of the important cause associated with the respiratory problems, and commonly it is neglected, and continuous unremitting or worsening symptoms. But before investigating, identify mimickers like recurrent allergic rhinitis identified by a positive family history of allergy examination, finding of the nasal mucosa, edema, hyperemia, clear nasal discharge, post-nasal drip, cobblestone pharynx, response to antihistaminic, absence of fever, and other allergic diathesis. And other is recurrent viral infection associated with that may mimic that of a lower respiratory tract infection, normal X-ray with or without other allergy or response to bronchodilator, and there are multiple names given: episodic wheezing, persistent wheezing, all those things. They are mimickers of a lower respiratory tract infection. So it is important that even if it is a persistent upper respiratory viral problem, recurrent viral problem, if any of these things are there, investigate. So now we come to a slightly more complex case. This is a 16-year-old girl, but she was in our follow-up since 1996, and this is in 2004. That presenting complaints were for age of 6 years, recurrent pneumonia, not growing well, recurrent loose stools. And on examination at age of 4 years, she is severely malnourished, and there was a clubbing. So it is important that multi-site infection and lower respiratory tract infection, severe infection, multi-site, multiple. There is bilateral coarse crepitations, decreased breath sound, and other systems were normal. So chronic wet cough, recurrent exacerbations with clubbing, suggesting that it is probably a chronic bronchiectasis post-infectious with a wasting and stunting. Investigations apart from some pneumonia, some anemia, others were within normal limit. ESR was slightly on the higher side. Tuberculin skin test was negative. Gastric aspirate AFB was negative. HIV was negative. Bronchoscopy was otherwise okay, but broncholar lavage showed a strep pneumonia. Sweat chloride was okay, and X-ray you can see hyperinflation with some ring shadows, and HRCT you can see here that there is a central part of the lungs are showing rounded, dilated airway, that is a central bronchiectasis, and as I discussed yesterday, these are the signet rings in which the airways are bigger than the accompanying vessel, suggesting that there is a bronchiectasis or dilated bronchi. So obviously, multi-site infection, failure to thrive, clubbing, and chronic diarrhea, recurrent diarrhea with a bronchiectasis investigated for immune deficiency. And nitrobutyrazolium test, which is a screening test for CGD, was normal. CD4, CD8 were normal, but immunoglobulin profile suggested that there is a pan-hypogammaglobulinemia. Age of onset around 6 years with pan-hypogammaglobulinemia. So a diagnosis of these two conditions will come to your mind. Either it is a pan-hypogammaglobulinemia. If it is a boy, then X-linked, or if it is a girl, then probably it is a autosomal recessively inherited, and other possibility is common variable immune deficiency. And how to differentiate between these two? You get a CD19, CD20 if they are within normal limit, suggesting that it is probably a common variable immune deficiency. But if they are low, then it suggests that it is a autosomal recessively inherited hypogammaglobulinemia. So see, because of pneumococcus, she was given a penicillin, intravenous immunoglobulin every 4 weeks, and on follow-up, she gained weight from 10 kilo to 28 kilo. Puberty at age of 14 years, slightly delayed. Then decreased need for antimicrobial, and she passed examination in 10th with a 84%. And at age of 16 years, she developed pallor, generalized lymphadenopathy, abdominal distension, and hepatosplenomegaly. And at that time, because of underlying disease and disease in our follow-up, we thought whether we are dealing with some Epstein-Barr virus infection, HIV, CMV, or acute leukemia. And the lymph node showed atypical cells, bone marrow suggestive of acute leukemia, and CMV PCR was negative, EB virus monosport was negative, and repeat HIV ELISA was also negative. So it was a common variable immune deficiency with acute leukemia. This case highlights that recurrent or LRTI with clubbing, think of bronchiectasis due to PCD, cystic fibrosis, immune deficiency, and if there is a central bronchiectasis, you will think of allergic bronchopulmonary aspergillosis, aspirations, immune deficiency, and cystic fibrosis. And this case tells us that even if you have made a diagnosis of any illness which requires a regular treatment, need to follow them up, because many of these conditions may develop some other complications later on, like our patient developed acute leukemia subsequently. And these are few clinical pictures of a Griscelli syndrome. This is a Wiskott-Eldrick in which there is eczematous dermatitis. This is ataxia telangiectasia, there is telangiectasia, and this is a SCID child with disseminated severe combined immune deficiency with disseminated BCG disease. Another common condition, asthma. And so this 14-year-old boy presented with recurrent cough, cold, wheezing, breathlessness since age of 4 years. Hospitalized several times and ventilated at age of 3 years in Chennai. And he is on all treatment including fluticasone, salmeterol, metered-dose inhaler, salbutamol, oral steroids, frequent courses, required 6 courses in last 12 months. You have to assess it on this chart that the child had a daily daytime symptoms, frequent nighttime symptoms, needs SABA twice, more than twice weekly, activity restriction, and FEV1 is less than 60% of the predicted. So this time he was admitted with us with an acute exacerbation and required ventilation for 2 weeks. So as we always tell you in whatever workshops and for management of asthma, so reassess the diagnosis as this goes, that symptoms are symptom complex and course of illness and imaging are classical of asthma. So always be ready if your patient is not improving with your treatment, that I'll revise the diagnosis. So it was asthma only. Treatment regime, adherence, inhalation technique was good. Comorbidities like rhinitis, he is getting treatment for that. And environment, no obvious abnormality. And even if required, we may have to send your social worker or nurse or yourself visit the home. So now how to manage it? So this is his hemogram, more or less normal, increased bronchovascular marking in the X-ray, and CT is also normal. IgE was high, 560, and against aspergillus, that indicates whether I am dealing with the allergic bronchopulmonary aspergillosis if it is more than 0.37. So it is also not suggestive of ABPA. Generally, ABPA you will consider if IgE is more than 1000. So how to manage him now? So we made a diagnosis. It is a therapy-resistant asthma. So IgE-mediated severe asthma, not responding to appropriate treatment with good adherence and no adverse environmental factors. So we continued with the inhaled corticosteroid long-acting beta agonist and added omalizumab every 4 weeks for 16 months. And there was a significant improvement in the asthma control. No daytime symptom, nighttime symptoms were controlled, no restriction of the activity, and not requiring frequent courses of steroids or salbutamol. And no hospitalization and attending school normally. So this is our responsibility. So this is, I re-emphasize, IgE-mediated asthma which is not controlled with a good adherence to appropriate treatment. Think of adding omalizumab. So lessons learned from this case is asthma is a heterogeneous disease. Majority of children responds well to treatment guideline, whether you follow the BTS, whether you follow the GINA guideline or other. Aim of managing asthma is, this is responsibility of whoever is treating, that my patient or my child should not get a lung attack. Lung attack is exacerbation. I will not get satisfied with that, yes, he is slightly better, he is not requiring hospitalization, but he or she should not get again. And that would be achieved by personalized treatment. And personalized treatment would be that I'll assess the child that why he is not responding, whether it is a IgE mediated, whether it is a eosinophilic inflammation, or whether it is a non-eosinophilic inflammation. And individual patient will require a different treatment. So this is very important that we should see that I am not satisfied even if my patient or my child gets a single attack of exacerbation requiring a casualty visit. And for that, if patient is not responding, don't shy away with taking a consultation with the pediatric pulmonologist. So this 7-year-old boy admitted in somewhere in 2016 with fever, cough and pain abdomen, and constipation. Examination, he is a febrile child, and otherwise he is okay. No pallor, cyanosis, clubbing, icterus or pedal edema, rest is NAD. And X-ray chest as part of pyrexia may be passed as normal, but we thought that there is some soft tissue over here. And that's why I got a CT scan, and you can see in a mediastinal window, there are conglomerate nodes with some hypodensity in the right paratracheal and subcarinal region, but no peripheral node. So in such a situation, what shall we do? One is that we need to document whether it is a lymph node enlargement which is responsible for fever, and mediastinal lymph node, no peripheral nodes. If peripheral node, if there is a pulmonary lesion, you will do treatment, investigate for the tuberculosis, TB or lymphoma or some other cause of this thing. And child is just a 6 or 7 year old, so how to go about it? And as you can see, you cannot do a CT guided aspiration in this child. So there is a new modality that is called EUS. EBUS is endobronchial ultrasound, and then you put your, in the real time, you put your needle. Like here, we are putting this thing through esophagus, and this is a lymph node which is in the subcarinal region. Under real time ultrasound, you insert a needle through your scope, and you can see this needle is there. So it is something like doing a FNAC from your cervical lymph node or axillary lymph node. So you do this type of sampling, and you send it for the cytopathology gene expert and MGIT, and you will get the diagnosis. Patients can be confirmed by doing a gene expert in childhood intrathoracic TB. In gene expert or CBNAT is one of the very important research tool. So and now in the clinical practice. So if you do a gastric aspirate or induced sputum 2 samples in 100 children, you may be able to identify by gene expert 34 children. So it becomes 34%. And if you do a broncholar lavage, after this, say remaining 66 patients, in which there is no evidence, but pre-test probability of tuberculosis is high because of the clinical radiological finding, you may be able to add another 35, that becomes a 54% cumulative. And this was documented by various studies carried out at AIMS. And if there is only lymph node and no this thing, then another 10 patients, if you do it, then 6 out of that may be confirmed. So you can see that total of 75%, which is reaching to a nearing to the adult patients in whom you are able to identify microbiologically confirmed TB. So the lesson learned is we should try to document TB by available resources. I am not suggesting that every patient should undergo a bronchoscopy or EBUS, but wherever it is available, our aim should be that instead of empirically starting on anti-TB drug, we try to document it, because two advantages. One is we are identifying microbiologically confirmed TB, and second thing is whether it is a rifampicin sensitive TB. So this Lakshita is from Bikaner, 3.5-month-old, recurrent cough and difficulty in breathing since age of 20 days, hospitalized thrice, had frequent stool and that were foul smelling and oily as part of, as told by mother. And she is not gaining weight. She is slightly anemic, some increase in the counts, but important thing here is that the ABG suggested a pH of 7.52 with hyponatremia, hypochloremia and hypokalemia. So this is one of the complex of these combination of these clinical features along with laboratory finding. So we thought that it may be cystic fibrosis, and sweat chloride was high, diagnosis of cystic fibrosis was made, and this case tells us that recurrent pneumonia, malabsorption with hyponatremia, hypochloremia, metabolic alkalosis may be a CF. And how, but sweat test may not be available. And in that situation, how to go about it. So based on our experience of having these clinical symptoms and these laboratory tests, basic laboratory tests which are available in most of the towns, we thought that we should try to develop a algorithm by using these. So one of the clinical algorithm was aquagenic wrinkling. So all of us are aware that if I put my hand in the water, then after 10-15 minutes my skin will get shriveled and then I have a aquagenic wrinkling. But it was observed that in children with cystic fibrosis it develops early. Within 3 minutes it will develop. So this was a study carried out at AIMS, and almost 81% of the children were developing these wrinkles on the palm and fingers after 3 minutes in children with cystic fibrosis, but it happened in the others also. The specificity was not very high. So we use this as one of the clinical variable, and then I'll show you that how you can make the diagnosis. So how to do, if you are suspecting a child, you take the child's hand, dip it in the water, and after 3 minutes take it out and see if he has developed the wrinkles. And compare it with the other side, hand that will act as a control, and then you can have, if you use this as one of the clinical variable, then it can be utilized without too much of expenses. So if a child is presenting with recurrent or persistent pneumonia with bulky fatty stool or failure to thrive, if two of these things are there, you take a history of sibling death due to any respiratory illness, or sputum is positive for Pseudomonas. If these two things are there, say a child with recurrent pneumonia, and you are just taking the history, that pneumonia with failure to thrive or bulky stool, and if sibling has died of respiratory diseases, and sputum culture is showing Pseudomonas, then you are reasonably sure that I am dealing with cystic fibrosis with a sensitivity and specificity of around 85%. Still, I may lose around 15% of the patients. This is a probable CF, start treatment and follow-up. If these are not there, then other things you can take in account: aquagenic wrinkling, as I had shown you, hyponatremia, blood gas, metabolic alkalosis or stool for fat globules. If any out of these 4 things, if 2 are there, then again it will have a similar sensitivity and specificity. So you are reasonably sure that I am dealing with the cystic fibrosis and start the treatment. So this patient is a 14-year-old from Jaipur, difficulty in breathing on exertion, fast breathing, progressively increasing chest deformity, and history. I am not telling this thing details, but generally we miss this thing, that if a child is having this problem, he may be TB, he may be pneumonia, he may be asthma, but we took a history exposure to pigeon and it was there for last few years. And vitals, apart from some tachypnea, respiratory distress, he was managing 95% oxygen saturation. There was pectus excavatum, use of accessory muscles, expansion was only 2 centimeters, bronchial breathing, crepitations, and increased vocal resonance in some part of the chest. And you can see there is some heterogeneous reticular nodular opacities, and these are ground glass opacities. And you can see in a mediastinal window that this is main pulmonary artery and this is aorta. So pulmonary artery, if it is more than the aorta, it suggests that there is a pulmonary arterial hypertension. So this child has a GGOs, cluster of these patchy consolidation with some pulmonary arterial hypertension. And if you do a spirometry, then it is typically very small, though this is the normal curve and this is a small curve, and this suggests that it is probably a restrictive disease. So because of this pigeon and these other things, we thought of that it may be a bird fancier's disease or exposure to pigeon causing hypersensitivity pneumonitis, and it was IgG was high, so a diagnosis of interstitial lung disease, chronic hypersensitivity pneumonia due to pigeon exposure, and pectus excavatum. And now we are finding more and more cases of this type of illness, and started on steroids, improved, and advised to break the contact with pigeon. So highlights are shadows on X-ray or CT scan in children with chronic respiratory may not always be due to pneumonia or TB. All shadows may not be due to infection, so antibiotics may not work in all. Respiratory illnesses started related to environmental factors should be kept in mind for all chronic diseases, and good history gives clue about the underlying illness in majority, not to shy away for taking expert opinion. So as you can see, this patient was roaming around, he was taking treatment and anti-TB drugs and all antimicrobials, but just the history of pigeon exposure. And because I belong to Jaipur, I asked from where you stay. They said we stay in Jalebi Chowk, and that is one of the area in which there are a lot of pigeon. And then that gave the clue, and then diagnosis was very clear at the same time. This 12-year-old girl, Begusarai, and then she came with a fever, cough, intermittent breathing difficulty, and all this is shorter duration. And she is having a blood stain expectoration. And you can see low-grade intermittent fever, undocumented, with insidious onset dry cough and hemoptysis, with breathing difficulty which is progressing. And there is a reduced appetite and weight loss. And these are classical, that whether I am dealing with a tuberculosis or something similar. And examinations is febrile, tachypnic, and respiratory difficulty, hypoxic, pallor. Along with that, there is a clubbing also. And air entry is reduced on the right side, inflammatory infrascapular area. Vocal fremitus is increased in the right inflammatory infrascapular area. So just to say that you have to be very thorough in clinical examination of a child who is dealing with respiratory system. In pediatric specialties, there are two types of physicians. One is bench-side physician, another is bedside physician. So if you are interested, younger generation, in respiratory, then you have to be a bedside physician. You have to check your patient daily, thoroughly. Because you cannot be seeing the X-ray and saying that child is having a wheezing or there is a lymph node tuberculosis. So you can see here miliary shadows with a cavity, and CT scan again showing a very large pulmonary artery, miliary shadows, random miliary shadows, and because of this thing, pulmonary hemorrhage, she got a CT scan, and you can see the right bronchial artery, which is not seen generally if it is not large, is responsible for bleeding. And so the first thing was to control this mastohemoptysis. So we have to depend on our intervention radiologist, and they did this thing angiography, and after localizing it, they could block this vessel, and the child was stabilized after embolizing it. And then investigations were carried out side by side, and it was confirmed, microbiologically confirmed TB, started on treatment. And at the same time, we emphasize that once you have made a diagnosis of tuberculosis in a family member, go ahead and do a family survey also. And mother was also suffering from tuberculosis. So this 1-month-old child presented with cough, cold, fever, difficulty in respiration, past history, family history, not significant, but tachypneic, tachycardia, chest syndrome, no cyanosis, decreased breath sound on the left side. And cardiovascular system was normal, abdomen was normal. And this was the X-ray. So X-ray showed a significant shift of mediastinum, and we always feel that I should put a ICD over here, it may be a pneumothorax. But before putting ICD, try to see whether where is the collapsed lung. Then only it would be responsible for it. So we are not able to find the collapsed lung. So there is a hyperinflation, shift of mediastinum, and this is the left lower lobe which is collapsed. And you can see CT hyperinflation. So how to decide whether it is left side is diseased or right side is diseased? So you look for the vessels, vascularity. Right side is okay, left side is stressed out, and there is low vascularity, suggesting that left side is problematic, and left lower lobe is collapsed, so it is a congenital lobar emphysema. She was operated and then followed up. So this 8-year-old from Bihar, recurrent cough, fever, breathlessness, wheezing, occasional vomiting, and doubtful dysphagia for 2 years. And no other contributory history. Treatment history, he received multiple courses of antibiotic, nebulized medications, steroids, and ATT twice in Bihar, and was sent to us for ruling out drug-resistant TB. And so important thing here is that child was having some improvement, but not completely normal. And when we were asking the history, though we had already seen the imaging also, mother gave the history that during sleep, food comes out from the nose and mouth. And this was the X-ray. Based on that, the child was sent to us as a mediastinal tuberculosis, which is not responding to anti-TB drugs twice. And when you get a lateral X-ray, this is a mediastinal widening, and lateral X-ray shows that your airways are pushed anteriorly, suggesting that there is something which is pushing airways. So this was a dilated esophagus, red tail appearance, suggesting that it was a achalasia, cardia, and he underwent surgery and improved. So this 11-year-old girl from Nagpur, born to a 3rd-degree consanguinity, and presented with persistent wet cough since neonatal period with recurrent exacerbations, persistent nasal and ear discharge, with malnourished and clubbing, having a bilateral crepitations. And you can see here that she is more or less daily symptomatic. Along with that, there was another confounding factor, that she had a foreign body aspiration, which was removed at age of around 2 years, and then he required hospitalization. So chronic respiratory problem, nasal and ear problem with wet cough, we thought of it is a chronic bronchiectasis, and X-ray shows that there is a shift, this orientation of heart is towards the other side, and there are some multiple cystic lesions. CT scan confirmed that there is a decreased volume on the right side as compared to the left side, with some bronchiectasis and hyperinflation. And paranasal sinuses showed thickening of the mucosa. You can see here, this is classical thickening in the maxillary sinus. And you can see this is a spirometry, which is, as compared to the earlier child, it is showing some scooping over here, suggesting that it is small, loop is small, but there is a scooping suggesting that there is a obstruction also. So this is a mixed type of pathology, and then you can document it by impulse oscillometry. Then, as I was discussing yesterday, nasal NO screening test for primary ciliary dyskinesia. So, as many of us may be aware or may be doing FeNO in asthmatic children, which will be raised, suggests that there is a eosinophilic inflammation in the airway. But here it is a nasal NO which is decreased, reduced in primary ciliary dyskinesia. So we developed a point of care test. So you can see this is you take a nasal sample and then you can see it under the light microscope, and you can document these ciliary movements. And of this girl from Nagpur, you can see these are cilia, but they are not moving. So there is a immotile cilia. And once you find this thing with clinical features, low this nasal NO, then you say that I am dealing with the primary ciliary dyskinesia. So the diagnosis of chronic suppurative lung disease with reactive airway disease with pulmonary arterial hypertension due to primary ciliary dyskinesia based on these things was made. Highlight of this case is persistent wet cough may be due to malformation, aspiration, primary ciliary dyskinesia, and PCG is an emerging illness. And clinical symptoms, persistent wet cough from neonatal period, recurrent pulmonary and progressive illness, chronic nasal and ear problem, and only 50% may have a situs. And high-speed video microscopy can be used, which is a low-cost screening tool, has a reasonable sensitivity and specificity. So that can be done to identify these patients. So this 3.5-year-old boy from Rajasthan, first born of non-consanguineous parents, admitted in May 2018 with complaints of poor appetite with significant weight loss for last 1.5 years, progressively worsening cough and dyspnea for last 8 months, and recent worsening of respiratory symptoms for 1 month. He is dyspneic at rest, bilateral diffuse crepitations or no wheezing, and he is severely hypoxic, 78% in room air with 95% supplementary oxygen with 2 liters. And these were the 3 X-rays at different age, 1.5 year, 3 year, and 3.5 year. You can see there is a diffuse lung disease, bilaterally left more than the right, and they are same, and he received anti-TB drugs, antimicrobials, and not responding. And then you see the CT scan. So this is crazy paving. You can see that there is a septa, and then there is a ground glass opacity. You can see here, this is our patient, and this is just to show you that why this is called crazy paving. Because there is a, this is, all of us have seen it, but so crazy paving appearance with background history suggests that it may be a, we are dealing with a PEP. And so we performed a bronchoscopy, normal bronchial tree, but it was a milky fluid. No growth of bacteria, fungus, AFB, no this thing. HLM is hemosiderin-laden macrophages, because that may be one of the causes for this crazy paving. And past positive material was seen on a staining. And so it was a diagnosis of pulmonary alveolar proteinosis was made. Of course, after that we got some mutations also of this thing. This condition is poor clearance of the secretions or surfactant is not unclear, and that's why these patients will continue to have accumulation of those secretions in the alveoli, and that is responsible for poor alveolar ventilation. So treatment for such a patient is whole lung lavage. You clear that fluid, and then at least once there may be some improvement. Some patient may not require a repeat one, but majority may require a repeat one. So how to do a whole lung lavage? So generally you would say that you will put a tube one modified this endotracheal tube. One side goes to the right side, one side goes to the left side. You occlude one side of the lung and you do a lavage in the other side. This is 3-year-old, and such a small, after 8 or 9 years, you can get the specialized this endotracheal tube, but it's not there. Then whether other option is that you put the child on ECMO and then his lungs can be lavaged. So how we overcome this problem? So we discussed it with our anesthesiology colleagues, and they said that yes, we can try. Of course, we are not very sure. So these two endotracheal tube of a small size, one with cuff and one without cuff, were inserted in the trachea. One went into the right side, one went into the left side, and then what you do is you inflate the balloon, and then you continue to ventilate the child from that side, and from other side you put the saline and then you drain it. So you can see from the right side, this is the these secretions which were blocking this alveoli, and this is from the left lung. So this is the whole lung lavage carried out by a modification, and despite you are not having the, it may not be possible to have a ECMO for such a small child, or it is expensive. So you can do this with your modification. So after whole lung lavage, you can see here, there was a significant improvement, respiratory rate reduced to 24 per minute, and his room air oxygenation was more than 95%. There was some indrawing was still persisting. This was the X-ray before the whole lung lavage, this was after the whole lung lavage, and you can see it crazy paving very clearly over here after this thing. This part is completely clear. So this is something like we learned that though now most of the centers may be able to afford ECMO, but if it is not possible, we discuss it with our colleagues and try to find out some way by which we can help the patient. This 11-month-old resident of Kolkata came with sudden onset of difficulty while feeding dal forcefully 1 month ago, and he continues to be tachypneic, 56 per minute and 160 per minute with oxygen saturation of 92%, chest bilateral crepitations and bilateral central hypodensity you can see in the X-ray, dense consolidation. And there is a marked increase in the TLC with polymorphonuclear response, dense consolidation, and then because of our previous experience, we thought that it is lentil hypersensitivity, which was confirmed, and then we started the child on prednisolone. And you can see after 6 weeks, there is a significant improvement in the X-ray as well as clinical condition of the child. So lesson learned is lentil aspiration is a unique entity which goes under-recognized and frequently mistreated as with pneumonia, with anti-TB drugs, antibiotics. With reticulonodular sedos with prolonged febrile respiratory illness, it can mimic that of a miliary TB also. And most probable mechanism is hypersensitivity to lentil antigen, and it fulfills the case definition of hypersensitivity pneumonitis. So rapid improvement with modification in feeding and immediate improvement, rapid improvement with a steroid. So this is a new entity which we should be aware about it. To summarize, in pediatric practice, as I had shown you, if you are a general pediatrician in your OPD, 40 to 50% of your patients may be children with respiratory problem. And it is relatively common, and even if it is a general hospital, pediatric ward, almost 35 to 50% patients may have some element of respiratory problem. Good history and examination with a careful interpretation of preliminary investigation. So it is important that we spend time getting the history and examination. I tell you about history, just last week only, we were doing a bronchoscopy of one child referred from our next door hospital, Safdarjung Hospital, and the resident had brought the X-ray CT scan, and then we were considering that it may be a surfactant protein related problem. I had not seen the patient, but based on history and examination and X-ray CT, we said that we will do a bronchoscopy. And then mother brought the child. When I was taking a history, after seeing the imaging, I asked mother whether you are putting any oil in the nose or in the ear. And she said, yes, I am putting it since day 3 of life. And then the diagnosis pre-test, even without doing a bronchoscopy diagnosis, was very obvious that it was a lipoid pneumonia, but this history was missed. Okay, so if investigation for final diagnosis is not available, don't worry about that, but at least give a label and be ready that I'll revise my diagnosis if I go wrong. May use a cost-effective test that may be suitable for our country. CF, PCD, ILD, these are emerging illnesses. All lung shadows may not be due to infection. Look for non-infectious causes and need to develop a management protocol that is suitable for us. This doesn't mean that we are undermining care of our children, but we should not be depriving them of appropriate care. Say we are aiming to reach to a appropriate treatment of child with cystic fibrosis as it is being given in London. But if I say that is not available because that costs around 25 lakh rupees a month, then whether I should not give the treatment of at least physiotherapy, appropriate antimicrobial and nutrition. So that may improve the quality of life as well as their familiar life. Thank you very much.
Thank you, sir. Thank you, sir, for sparing time for to coming to Kolhapur. And sir is actually heart of AIMS Pulmonology, Delhi. So, sir is actually, we are actually fortunate to get sir as our speaker. So again, thank you very much, sir.
Thank you very much. I feel very much proud that I also belong to Maharashtra.
Thank you. Thank you, sir. Thank you, ma'am. Moving on to the next session, thrombocytopenia decoded with case scenarios. The speaker for this session is Dr. Abhilasha Sampagar, ma'am, and it will be chaired by Dr. Preeti Naik, ma'am, who is a practicing hemato-oncologist from D.Y. Patil Hospital, Kolhapur, and Dr. Sushma Kore, ma'am, who is a renowned pediatrician practicing in Nipani.